to share Mastacon platform. Thank you to Dr. Kuthe, who has really given a personal privilege that I could reschedule my talk. And it's indeed a pleasure again to address the youngsters here, because initially our plan was, okay, maybe we'll have a lot of other consultants who may come across some IVF or infertility patients in their own families, in their friend circle or among their patients. So accordingly, I had actually planned my slides so that when to refer a patient was supposedly a talk for today, considering all other consultants. But honestly, let me be very frank with you all. Are you all guys okay with this, or should we have a mock one-on-one? Say quickly 10-minute session. I'm okay with that also. Which year are you all in? You're all MBBS students, right? Which year are you all in? Third year. So you are exposed to OBGYN, isn't it? How many of you are actually interested in OBGYN? None of you. Okay, so let me quickly take you. Okay, one girl I can see. Welcome to my team. Otherwise, generally what we see is IVF is a topic which not many people are aware of. At least I thought, okay, I'll put some light on it. What exactly is IVF is? Once upon a time it was called test tube baby, in vitro fertilization. Today we call it in the name of ICSI, intracytoplasmic seminal injection, if you have heard of. Of course, it will be one of your exam questions also. And keeping that in mind. So what do we do here is, when we are evaluating a couple, quickly to talk about what is IVF, I'm just taking 1 minute. When we are evaluating a couple, when do we treat an infertile couple? When they are planning to have a baby naturally, but they are not able to conceive for more than 1 year. So till 1 year, you really don't give too much of importance. But if the mother, the patient, the woman's age is more than 35, you start treating her immediately. Okay, start investigating and start treating. So if they have been trying for more than a year, try using ovulation induction agents like letrozole, clomiphene and all those. Maybe gonadotropin, some injections. If that doesn't work, then switch over to IUI. When even IUI or intrauterine insemination doesn't work, we switch them over to IVF or in vitro fertilization. So when should you think of, yes, I should consider this for a patient, is our crux today. So this is our beautiful Sairip hospital at Ahmednagar, a 300-bedded hospital which has all multi-specialities right from basement to the top floor. We have cardiac, neuro, ortho, you name it, and all of them. In fact, today we are running a very, very good genetic center also, I can proudly say. In that, my pride is definitely my OBGYN unit. Anyone who is willing to see can always visit. It's on the 4th floor, I would say. It's all beautifully designed, like a labor room and then OBS, OT, NICU, and our IVF lab. So nowadays we see that many more couples, many more are coming, more and more people are trying to conceive. Almost the incidence of infertility is increasing to as high as 15%. And though the increase in incidence is noted, you all know very well, because considering late marriage, late conception, not willing to have a baby, career-oriented women, many factors, that is what is urging them to get married a little late and then having a baby. So in that, but people are on the contrary becoming more aware that ART treatments, mind you, ART is not artificial reproductive treatment. Many people get confused. It is saying artificial. There's nothing artificial in this. It is assisted reproductive technique. Okay, assisted. Sometimes even small things will need some help. So that is when we call it as ARTs, assisted reproductive technique. And nowadays with newer advent and technologies, all these have many patients themselves are opting. Mala thoda motha treatment lagto, and fast forward, we don't have patience, make it fast, and all these things we can think of. So once upon a time when we were talking about IVF for a couple, it would be 99% tubal factor. If you remember your infertility or whatever your OBGYN posting, tubal factor is when a lady is affected with tuberculosis or something, she has a permanent damage of her fallopian tubes. That's when she cannot conceive naturally, when the patient has to be offered an IVF. And also other reasons which I will gradually, I'll show in a couple of the slides. At the same time, whenever we are talking about bigger treatments, you should also counsel them. There could be some disadvantage. Any treatment, we always say there's a plus and a minus. The minuses is obviously greater expense, almost एक cycle 1 से 3 लाख पर्यंत खर्च लागतो. And number 2, there could be some complications. Though many people are getting fascinated, twins. We all know multiple pregnancy has its own minuses. So keeping that in mind, we should be diligent enough in understanding who requires what, and accordingly that treatment should be tailor-made. So it has to be individualized, and you should avoid all these unnecessary risks due to over-treatment. At the same time, try avoid delay also. Referring the patient at the right time is most important. So whenever we are talking about an infertile couple, one is either the female has some issue or the male has some issue, or it could be a combination factors of male and female, or if everything is normal, it is called as unexplained infertility. Even the male parameters are good, her egg producing capacity is good, her uterus is good, tubes are good, but still they are not able to conceive. That is when the most important thing what we come across nowadays more and more is unexplained infertility. So when should you think of conditions like how I have shown you, it's a test tube baby, or to know a little more female factors, what are the important ones, like how I said tuberculosis. Tuberculosis is really a very dangerous situation which Indian population women are still encountering when they come up with the history of scanty menses, irregular periods, loss of weight sometimes, vague symptoms, anorexia and general, debilities and such things. But when you typically see that they are unable to have babies at the right time when they are planning, one reason you should keep in mind is definitely genital tuberculosis, where it could be due to peritubal adhesions and the rigidity. Literally the tubes become like rigid walls, post-pipe. So this is the typical picture on our X-ray or HSG what we do. That's the uterine cavity and bilateral tubes. Normally the fallopian tubes are hair like beautifully you can see, and there is a spillage of the dye. When we push the urographic dye, the dye falls out like a, when I talk to a patient it is like a, that fountain, okay? But here, because there is a tubal damage, there is no free spillage, and obviously when the tube is damaged, it's a little difficult. And also the number 2 reason where the tubal factors are involved is ectopic pregnancy. Because what is ectopic? We all know tubal pregnancy or pregnancy happening in the fallopian tube. So with that, we may have to excise the tube. Obviously the patient has no fallopian tube, then you have to consider doing an IVF. Some of the ovarian factors, when we talk about the uterus per se, it's the uterine, cervical, fallopian tube and the ovarian factor. Coming to ovarian factors, the most common reason where one resorts to IVF is PCOD. How many of you have heard of the word PCOD? Hanwar please. Very, very common. See, this is a big chunk who already know. PCOD is something which the newer population is facing with because of, like how I said, lifestyle, diet, lot many more factors involved. Because of that, the egg producing capacity is definitely disturbed and the quality of the eggs comes down. So because of that, they may require a little higher injections and they may have to resort to IVF. Cervical factors, like how I said, when you talk about the anatomy, there could be some cervical antibodies or 4 to 6 cycles of IUI also have failed. That indicates probably something is wrong with the cervix also. Endometriosis again is a very important topic where both the ovaries are repeatedly getting filled with hemorrhagic cysts or the chocolate cysts is what it is called as. So in that case again the quality of the egg is compromised. So the egg which is released once in a while also may not be able to fertile on its own. So they may require a little extra help. भले surgery हुआ होगा उनका, फिर भी repeatedly adhesions, the tubo-ovarian relationship gets abnormal, because of which they find it difficult to conceive. So one may have to resort to an IVF in such cases. And some cases like, nowadays again we see a lot of women with due to stress factors or genetic conditions, lifestyle conditions, they end up in premature menopause or premature ovarian failure. PCOD was one extreme, whereas on the other extreme, ovarian failure, when they are not able to produce eggs at all. Even in such patients, you should consider not to waste time and consider it faster. And in some cases, nowadays you must all have heard of egg freezing. Have you heard of it? You see a lot of posts, even now Jennifer Aniston writing a lot of things that I made a mistake in life, I've done that. She was not aware of egg freezing, but now this generation knows a lot about egg freezing because all these career-oriented women who are getting married late, planning children late, they do freeze their eggs before, consider their path. Again, when they are ready to have a baby, they consider thawing of the oocytes, consider the partner, and make babies and get transferred, and they can still become beautiful mothers. So whenever you are thinking of donor oocytes, donor embryos, once upon a time this concept was not so clear. So we had to, end of the stage when the patient comes with 0 eggs, then we may have to consider egg donation or sometimes member donation also. And number 3, very disastrous condition when somebody has been diagnosed with any cancer in the body, women especially, they're still not aware. I have a 17-year-old girl who was diagnosed with an ovarian cyst basically. but routinely we did a laparoscopy, set it. Unfortunately, it turned out to be a mature teratoma. Mature teratoma, mind you, is kind of a malignancy. So we had to sacrifice that ovary, and the other ovary again after 6 months got up. Now she was advised for chemotherapy. Be it with one ovary, but with chemotherapy. That was the time I had to pitch in and tell her to the eggs freeze कर, must go for chemotherapy. You know, that's where we have to take the right intervention. And fortunately, she did that. And then now her chemotherapy also got over. She's rid of the disease, and her eggs are still beautifully lying with us. Okay. So sometimes when she wishes at the age of 25-30, she can still get pregnant with her own eggs. Equally important, like when we talk about female factors, is male factors. Not to ignore them. Again, due to lifestyle, wrong culture, I mean, how should I say, a lot of stress, smoking, alcohol, all those we know. We see a lot of decrease in the sperm count, motility and morphology. So whenever you are talking about any semen parameters, mind you, you should keep all three parameters, not just number, madam 30 million hai, tarika nahi raha. It's not only the akda number. It's the more important factors in that is motility, grade 4, should be there, grade 3, grade 4. And number 3, most important is morphology. When we talk about the sperm, all of you, if you know of it, Wiki donor also shows it. A head, a mid-piece and a tail. If any of the defects are more than 60%, please consider an IVF, not to waste time in any other treatments. There could be some other autoimmune components like autoimmune pathology in the mother, going to be the mother or the female partner, or anti-sperm antibodies, where again you try 10 times, they conceive but they keep aborting. Again, you have to work up properly and then take them for an IVF with good counseling. Like how I said, unexplained, when all other factors are normal, still they are not able to. There could be subtle changes in the ovarian level or gamete transport level, sperm and abnormality, tubal environment, lot many more things are involved. It's not just because when I talk about IVF, like how I said, I'll quickly tell you later what are the things we look into that, so that you are aware. You know, okay, these are the itna gehrai mein hota hai. Natural physiology sometimes can take a little deviation also. And whenever a patient, a male comes with an azoospermia, you all must have heard azoospermia is 0 sperms when he ejaculates. In that, not just one sample, you have to of course repeat and check once. And if that is the case, we do these procedures on the testis, where we take out by doing a micro manipulation, try to extract the sperms and make babies. So these beautiful things can happen only when you consider an IVF. And the next important, very beautiful genetic. How many of you are involved, interested in genetics? I would say 100% please look into it. Because the more and more we are working into that direction, I am understanding that they are naturally conceiving, but the baby is anomalous, baby ka brain growth nahi ho raha hai, spine defect ho raha hai, or something, you must have heard of all this. So now what we do is, before she gets pregnant, we check on the embryo, whether that embryo is affected with a particular gene. In fact, with pride I should say, yesterday we did a PGD. That lady, the couple, both of them have Sandoff's disease, which is a heterogeneous, they are heterozygous carrier, where their child, she had 3 abortions at mid-trimester, at 16 weeks, because that baby's brain is not growing well and lot many more things. One baby was born, but it was totally mentally retarded. So she was totally devastated. So we did her PGD, in which her embryos now will be tested, whether that gene, the embryo is carrying that gene, and then it will be transferred, provided the gene is, the embryo is normal, okay? So that's the advance of sciences which have come up, and I hope I could throw some light and make you all aware that don't give up. अरे नहीं हो रहा है, नहीं हो रहा है. अभी भी खेड़े गांव में होता है. I'm sorry to say that नहीं दत्तक घ्यायचे मॅडम किंवा काही आता देवाने एवढंच दिलेलं आहे आम्हाला काही होणार नाही. All these we still get to hear, but I think we as clinicians should always promote them, help them get their beautiful babies on their own. Whenever we talk about anything, it's not that I feel she needs an IVF, you feel. There are some standard guidelines which also say that yes, IVF is the modality. When, like how that also says, nice guidelines are the standard ones which are the UK protocol. They say that you always have to discuss the risks versus benefits, like how in the beginning I said. And any woman under the age of 40 should be offered at least 3 to 6 cycles of IUI. Mind you, when I'm talking 6 cycles of IUI, it's not easy. Any couple, repeated cycles, they keep on coming to you. Azuni gave her one period, second time again period, third time again. It's a little demoralizing for them also. So you have to boost them, okay, this is the time you can shift from an IUI to IVF. and consider little better treatment. And in that particularly, like how I said, in the beginning, before era, we will do IVF. Like you put the egg in a petri dish, put 4 to 5 sperms, whichever is the best, will capacitate by itself and become an embryo. But now we don't do it. What I said was ICSI. ICSI is we hold the egg, micro manipulation, literally you penetrate intracytoplasmic injection of the sperm and you make the embryo. After 3 days, you check the quality of embryo, grade 1, grade 2. That's the beauty, when you can always confidently tell the patient, yes, you have beautiful grade 1 embryos. Then keep them for blastocyst. That's all a beautiful thing, what you can see on a big screen. You show the pictures to the patients, they also feel happy. Yes, my baby is
2 minutes.
Yes, done. So that's how you can proceed and always think of. So, like how I said, wherever is required, you have to consider. Patient selection for referral, again, very important. Before even sending the patient, basic things, sometimes some people tend to forget. Get the local examination system income. Sometimes they would have ruled out, missed out diabetes or all these histories in the partners. So kindly elicit all those. A detailed semen analysis, screening basic for HIV, HBsAg and HCV. Endocrine parameters, if the male is azoospermic, doing the same parameters like LH, FSH, E2, prolactin, all those like females, have to be done on the male partner also. On the wife, same things, all these, detect the time of ovulation by doing a follicle study, check the tubal patency, basic immunological, all these tests, and hormones. In this, the take-home message is please get the woman's AMH done, anti-mullerian hormone. That is the most important one which we tell her, ovarian reserve, how many eggs she can produce, what is the quality of eggs. So with that, our counseling starts, okay? So the key points, like how I said, IVF is a test of fertilization. They come to you in the last end stage. I also tell her, Sharanagati Sanga Dumi Hath Var Kara Mangui. That's how we always have to counsel, because whatever said and done, our efforts and above and all, God's grace. So like how I said, sometimes nature, like how I said, normal physiology to procure and have a baby, that also requires little help. So let us have some compassion towards these couples, not to give them any, encourage them to go for further treatments. And it takes pride, I take this pride to show a few of the pictures of my IVF center, where we have all these facilities, including Mesa, Petsa, Tisa, all these testicular aspirations and biopsies and PGD, genetic tests, everything we have been doing on and off. And fortunately, we are able to tell the patient, that's what, see, everything is evidence-based today. So I am talking something there, Dakwa Mata record. Everything is foolproof. We show them, it's all there, and these are some of the beautiful babies of IVF what we have delivered. In case many people still have that fear that normal Rahanaka Mata they are in fact more intelligent is what I can always tell them and give them reassurance. So having a baby is like falling in love again, both with your husband and your child, is what I always counsel a mother who is an expectant mother, is what I can say. And I thank you all for giving a patient hearing, and thanks once again. This was just a bird's eye view. It's IVF, like how I said, it's still a very, very enormous thing where you have to literally get into the ocean and deep dive and come out. So why we tend to talk such things is not so that so many sciences are advancing. Like the other day we had called Dr. Javali for one of the cardiothoracic, he was among us, like all general doctors. What do we know about CTVS? To know, but such a senior man talking, then I said, oh, ye bhi hai, wo bhi hai. That's what we got to know. So I hope it got some more information to you all, and thank you so much once again, Dr. Kude and the whole team for giving me this opportunity. Thanks.
Thank you so much, ma'am, for your session. Now, I would like to call on the stage Dr. Utkrant Kulekar sir and his team. They are here from Dinanath Mangeshkar Hospital, Pune. They are here to share their insight on the topic, management approach to acute pancreatitis. And for the session, I request Indranil sir to chair this session.
Good afternoon, friends. At the outset, I would like to thank the organizer and the organizing secretary, Dr. Kutte, for the privilege of this talk. It's indeed a pleasure for all of us to be here. When Dr. Kutte told us about this prestigious meeting, which would be attended by a diverse audience, what I thought is, rather than talking about some cutting-edge technological advance in our hospital or about the niche subspecialty work, maybe we talk on a common topic, which is fairly common, fairly prevalent, where general practitioners, internists, general surgeons get involved in the management, and which even today is a challenging problem. And one such topic is acute pancreatitis. Because there is a fair amount of young audience in the crowd, budding doctors, I've made some last minute modifications to this topic. I'll make it concise and try my best to make it as interesting, especially for these newer doctors on the right side. In fact, in a lighter way, Robert Zollikow, a great pancreatic surgeon, talked about pancreas as being an untrustworthy organ. And Harold Ellis, a famous surgeon of the yesteryears, talked about God putting the pancreas in the back because he did not want surgeons messing with it. So without much ado, if I can set the ball rolling, I would like to ask Dr. Kurlekar as to what are the diagnostic criteria of pancreatitis. When can we say that this patient of acute abdominal pain has pancreatitis? Is there a mic? It would be cumbersome for them to come here.
Thank you. Good morning, everybody. The most important features of clinical diagnosis, most of the times is diagnosed clinically. Acute pain in abdomen, mainly in the upper abdomen and left hypochondriac region. It generally radiates to the back. The patient prefers to sit rather than lying down in the bed. And he has some amount of tachycardia which is seen there. There are some markers which we do. Basically, it is serum amylase and serum lipase. However, if these markers are raised more than 3 times the normal level, then these are diagnostics. Ultrasound might not be diagnostic in the initial phase, and if you do the markers even in later stage, after 2 or 3 days, they might fall down below the normal levels, and then it might confuse your diagnosis.
So this is what I think you all should be aware of: biochemical, clinical and radiological criteria, and if 2 of the 3 corroborate, then we will say this is acute pancreatitis. And these are the features of pancreatic pain which Dr. Kurlekar just elucidated, and Moynihan used to talk of it as limitless agony, very severe pain. I would like to ask Dr. Kurlekar, are there any limitations of pancreatic enzyme estimation? And I think he had answered that, and he did allude to that the amylase levels after 2 to 3 days are going to fall. And there can be some clinical situations, especially if we estimate amylase late in the illness, acute on chronic, where the gland is already damaged to an extent and the amylase levels are not that high. And an interesting phenomenon of hypertriglyceridemia, where the triglycerides themselves are going to interfere with the calorimetric assessment, and if one dilutes the serum, the high amylase levels are unmasked. Now, it's not uncommon for us as clinicians that we have an anxious call from our referring doctor saying that he is referring so-and-so, and his amylase levels are 3000, more than 30 times the upper limit of normality. I would like to ask Dr. Gadikar, is there any relation between amylase levels and severity of acute pancreatitis, as one would expect in most of the problems? The levels is a reflection of the severity.
So yes, that is a very, very pertinent point. The amylase and lipase levels are generally used only for the diagnosis of pancreatitis. So if you have patients with high amylase and lipase, it generally tells us that this patient has got pancreatitis. The severity of pancreatitis is not decided on the level. So 500, 1000, 3000 does not change the severity at all. What changes or what decides the severity is actually the clinical presentation and some imaging. I think we can allude to that later, but it would be the few of the criteria that we use in our practice to decide severity.
Today when we talk of pancreatitis, those managing pancreatitis essentially should be aware that we are talking of 2 diverse sets of patients. One is clinically mild pancreatitis, which fortunately is the major group, 75 to 80%, which are going to recover within a week. And these are patients which can be managed in the setting of a nursing home, provided the treating clinician is aware of the basic principles. And then there is a group of acute severe, 20 to 25%, which is a different disease altogether. These are the patients who are more prone for complications, increased morbidity, there is a risk of mortality, and it's important to be aware so that these patients can be referred to a tertiary care center. They are the ones who need ICU care. I won't be going into the details of this. Again, now we come to this important question which I'd like to ask Dr. Gadikar. So, is it possible to predict as to the pancreatitis which we are dealing with? Is it acute mild or acute severe? So, the treating clinician can refer the patient at the right time. Can we predict the severity?
Yeah, so there are 2 or 3 very important points. One, as Dr. Kurlekar mentioned in the beginning, is the severity of pain. So one is the pain severity, the duration, which generally can go on. And the second important point clinically is these patients become restless and sometimes they start getting breathless. So there is what is called as tachypnea, as we call it. These are the patients where one has to be extra careful. One has to realize that these are patients who are going to develop some or the other, can develop some or the other complications, and these we have to be either be careful, or these are the patients who have to be sent off to higher centers and monitored in the ICU. So this particular phenomenon is called as the systemic inflammatory response syndrome, that is SIRS, and this is generally prevalent in patients with pancreatitis in the first 5 to 7 days. So many a times patients with tachycardia, presence of fever, are confused with sepsis, with infections, but generally speaking in the first 5 to 7 days, it is what is called as systemic inflammatory response, and one has to monitor these patients and treat them symptomatically, and most of them generally tend to, we can salvage these patients, but you must remember that in some patients of severe pancreatitis, there is an antecedent mortality about 8 to 10%.
There is one more score. I won't be going into the details of that in view of constraints of time. Those of you who are interested can note it by SAT score and later go through it. These are the investigations in acute abdomen, X-ray to rule out gas and the diaphragm, sonography, which as Dr. Kurlekar told is highly operator dependent. And the standard investigation for pancreas is a CT scan, pancreas being a retroperitoneal organ. I would like to ask Dr. Kurlekar as to when are you going to do a CT scan? Do we do it in all cases, or when are you going to do a CT scan?
To CT scan, I think in clinical practice we do it at 2 occasions. One, when you are not certain of the diagnosis. You have pain in abdomen, your levels are not expectedly risen to the what levels you expected pancreatitis. So the diagnosis is not confirmed. You are unsure of diagnosis. That is one thing. And when you know that it is pancreatitis, and then you want to know how severe it is, whether there are any necrotic changes. But in that case, we generally do CT. It's advisable to do it after 3 to 5 days of onset of symptoms. That is when actually the changes start happening in the pancreas. So it's on clinical judgment that you decide when you want to do the CT scan.
We are lucky to have a radiologist in our panel with interest in abdominal imaging. I would like to ask Dr. Aditi as to, can you just further elaborate on the CT scan protocol? Could you tell us a bit as to how you are doing the CT, anything in particular which we as clinicians should be aware of?
Yes, a CT scan before 3 days, 3 to 5 days is not useful because it can be absolutely normal. Pancreas may enhance normally. A CT scan should be done on a helical multi-detector CT, and we give around 60 ml of iodinated contrast. A contrast enhanced CT scan is a must to rule out necrosis. The protocol which we use is we do it as a biphasic study. First is the late arterial phase, which is taken at 20 seconds after injection of the contrast, in which the normal pancreas will enhance. If they don't, we call it as necrosis. And a portovenous phase wherein we can determine other organs and associated findings as well as venous thrombosis. We use modified CT severity index by Balthazar, which was modified in 2014. The other severity index are no more used. There are three categories: pancreatic inflammation, pancreatic necrosis, and extrapancreatic complication as enlisted. The score is between 0 to 4 in each category, and it can be classified as mild, moderate, severe, depending on the score.
And can you just...
Yeah, so this is a case of interstitial edematous pancreatitis. This is a contrast enhanced CT image showing a bulky enlarged pancreas with loss of normal contour, and there is a lot of peripancreatic fat stranding as well as thickening of the gyrotas fascia. Since there is no necrosis, we call this as just edematous pancreatitis. This is a case of necrotizing pancreatitis. We see normally enhancing pancreas only in the head and tail region. The neck and body are not enhancing and are replaced by acute peripancreatic fluid collection, thus calling it as necrotizing pancreatitis.
Are there any limitations of CT?
So yes, before 4 to 5 days there is no role of CT because we cannot diagnose whether it is necrotic or not. And some contrast-induced nephropathy or damage to pancreatic microcirculation can be there. An allergic reaction can occur. CT scan will not pick up all the gallstones. Only 75% of gallstones can be picked up as they are radiodense. 25% can be missed. So ultrasound is better than CT in these cases.
This is what both our panelists stress. If you are doing a CT to stratify the severity, you better do it later, after 4 to 5 days. CT in the initial period would not really be that informative. And for picking up the etiology, sonography is yet better than a CT scan. I won't be going into. There are some cases which we encounter of deranged renal parameters, and there are special dyes which we can use. The patient has to be hydrated. And can you just tell us in brief of the role of MRI these days?
Yeah, so till creat level is 2, we can use renoprotective contrast with CT. If it is more than 2, however, the GFR is more than 30, we can still go ahead with MRI and contrast. MRI contrast is safer than the CT contrast, and it can give us all the information which CT can. MRI is superior to CT in differentiating between the fluid and the necrosis in the peripancreatic fluid, as well as additional use of MRCP can give us information about underlying pancreatic division or any other cause.
Now, if this is a graph of the pathophysiology of pancreatitis, and if you can see the blue line, the yellow line, it shows the cytokines and the leukotrienes and the inflammatory mediators. They peak typically after 24 hours. And the slightly pink line is the organ dysfunction, which happens at around 60 hours. So, if one were to sort of infer, there is a 36-hour gap between the two. So what it means is, can we do something in this period which can influence the overall outcome of pancreatitis? I would like to ask this question to the intensivist in our panel, Dr. Akole.
So I think a few things we can do to alter the severity and the outcome of the pancreatitis. One thing is to monitor very closely, and this apparently moderately severe disease should be managed in higher centers with good trained intensive care, and where there are a lot of diagnostic and advanced diagnostic facilities. Most important to monitor oxygen and support oxygenation to maintain a good level of circulation around 90-95%. And fluid volume resuscitation is the most important thing, which we can start in the periphery as well as go advanced into the intensive care.
So very basic things which can be done even at the nursing home level, just put the patient on oxygen and proper fluid volume resuscitation. So can you tell us about the fluid therapy and why is it important?
As we know, all tissue organ function depends on its perfusion, and this tissue perfusion is the most important thing that we should look at, rather than hemodynamic parameters like blood pressure and macro parameters. So if we can maintain perfusion, we can avoid the extent of necrosis, we can avoid further organ dysfunction. So giving adequate fluid therapy will prevent all these complications. How we do know that the pancreas is the
2 minutes remaining.
fluid loss is severe in pancreatitis? So we can just monitor hemoconcentration, rising bilirubin and creatinine levels, as well as your clinical parameters.
And I think what you need to understand, what we teach our students is, just as you have burns and you have read about the burns formula, pancreatitis is like a chemical burn, so a lot of fluid sequestration and you need to give liters and liters of fluid, and it's more important in the first 24 hours. There are time constraints, and that's the reason I emphasize more on the diagnostic aspect and the initial management aspect, where if some of you are interns, you can sort of use this knowledge to manage your patients. We can go on and on. I think in view of constraints of time, I'll directly jump to the key points. There were issues about fluid resuscitation, what precautions you need to take. Analgesia is important because that facilitates the respiration, and a pain-free patient has better respiratory dynamics. Octreotide or somatostatin has no role. Antibiotics, the role is very selective, only in patients with infection. This is an inflammation, it's not an infection, so universal use of antibiotics is fraught with problems. And nutrition is important. We had been taught as students about rest to pancreas, that's no longer true, and what we say is the concept of rest to pancreas has to be put to rest. So finally, friends, to conclude, diagnosis, you need to understand the 2 of the 3 parameters. Amylase levels, as Dr. Gadikar told, has no relation to the severity. There are these 2 diverse diseases, acute severe, pick them up early and refer them to the tertiary care center. SIRS, presence and persistence is a useful predictor. CT only selectively and after 5 days. As Dr. Akule told, analgesia, adequate fluid volume resuscitation and oxygenation is important. Aggressive fluid volume resuscitation in the first 1 day. Antibiotics selectively, octreotide no, nutrition yes in all patients. So once again, on behalf of the Dinanath Mangeshkar Hospital, I would like to thank the organizers for this presentation, giving us this privilege of this presentation, and thank you.
Session. Dr. Kutte and the organizing committee for inviting me here today, and I'm going to be really brief, and thank you for allowing me to speak before my session. So the topic is inside the mind of adolescents, and I guess the students here are still, they are just about out of the adolescence. Let me tell you the definition of adolescence first. WHO has defined that all those between 10 and 19 years are adolescents, and those between 15 and 24 years are youth, and those between 10 and 24 years are young people. So generally we talk about adolescents and young people together, calling them AYA. Now why is this age group important? Because it's a huge population. In India there are 253 million adolescents, and which comprises about 20% of the total population. And as we all know, it's a demographic force, it's an economic force, they are agents of change, and they are also nation builders. And they're changing in multiple ways, they're changing at multiple levels, they're changing physically, they're changing emotionally, they're changing in their cognition or thought process, and they're changing as far as their socialization goes. So we are going to talk about the changes in the mind and why does the mind change in adolescence. So there are certain tasks of each stage of human beings, and those of adolescents are to be able to handle the huge characteristic changes which are happening, gaining independence, forming new meaningful relationships, self-development, self-identity, and all these other things. And why do we want to peep inside the adolescent mind? To get insight into the adolescent behavior. All of us are always confused as to why do they behave like this. And many times parents say that, oh my God, I just don't know how to deal with this situation. And since this is such a huge part of our society, I think we need to know why they are behaving the way they do, to be better able to guide them, to handle them with empathy, and as well as to identify the high-risk adolescents. So this is a little busy slide and you don't have to read all of it. But suffice it to say that as earlier we used to feel that the brain development completes at 5 years of age. But now we know that it continues to 20 to 25 years of age, and actually we are learning all our lives, but majority of the software changes happen during adolescence. And what happens in the brain? There is a lot of synaptic pruning, there is myelination, and overactive limbic system. So their emotions are extremely strong, and their thinking brain, that is the prefrontal cortex, is still lagging behind, something which is rational, something which manages the emotions, and this causes discrepancy between their physical age and their emotional age. Also, the reward center is extremely strong and active, and so they look at immediate short-term rewards rather than long-term consequences. They are more of concrete thinkers, so they think of here and now, they think in black and white, and so they don't think about long-term consequences. And also the reproductive hormones, they also are necessary for the structural growth and functioning of brain. So it's not that just the brain is changing, but it's also the reproductive hormones which are contributing to the change in the brain. And so we have all seen that adolescents are risk takers. They are impulsive, they are curious, they are experimentative, and they are their judgment and decision making is very poor. Also, there is something called as use it or lose it, which means the pathways which in the brain which are used again and again, they are strengthened, and the ones which are not used are eliminated. And that's why we are concerned about a lot of things in adolescence. So are these changes even necessary? Definitely, it's from the evolutionary perspective, unless the adolescents were experimentative or unless they took risks, nothing would have changed in human beings, and we would still be living in the jungles eating raw fruit and raw meat. But because adolescents take risks, because they experiment, we have changed, we have evolved, and the mankind has progressed. Also, adolescents obviously give a lot of freshness and variety, and it is a law of nature, change is the only constant. So risk-taking and experimentation allows them to explore new choices. Lack of abstract or long-term thinking helps them in taking quick decisions. Like if an adult takes a decision, they will think of pros and cons, they will think of all the obstacles, and so they'll probably defer the decision, but they quickly take the decisions. They are called selfish or self-centered, but that is helpful for their own survival. And all the mistakes which they commit give them a lot of valuable experience. So what all things are affected? Most of all, adolescents are making new relationships. So they are reinventing their relationship with their parents and their family. Definitely they are very, very close to their peers, and they sometimes fall to peer pressure. They are forming new romantic relationships, and they are expanding their social circle. All these things are affected because of the changing brain. And also what we are always concerned about is the high-risk behavior that the adolescents do. So when it comes to driving, they know that they cannot drive without a license, but they still do this. They drive at high speed. Drunk driving and breaking traffic laws is very common. When it comes to diet, we know they love junk food, and even though they know that it can cause obesity and other diseases, they can't really resist it. Addictions, what we are very, very concerned about. We know that there is reinforcement of the pathways which are used during adolescence, and if they go to addictions, these pathways are going to be strengthened, and all those who start their addictions during adolescence are likely to become addicts all their lives. And so if we talk to addicts, most of them will tell you that they started during their adolescence. We are also concerned about unsafe sex, underage sex and abuse. And with the advent of technology, we are very concerned about their online behavior. So laws are actually made keeping in mind all these points. So the age cutoffs are used because the brain development happens at a particular time, and that's why driving license is not given before 18. It's not that they cannot drive. Technically, mechanically, they can drive the vehicle, but they don't know what to do in an emergency or how to make rational decisions. Also, other laws such as POCSO, protection of children against sexual offences, taking consent, all these things are made keeping this adolescent brain development in mind. And so we can use this information when we are making laws, we can use this information when we are guiding parents, we can make use of this while giving career guidance, teaching them responsible sexual and digital behavior, that is digital literacy. while giving them guidance about relationships and while teaching them life skills. So I think this is my last slide. These three pictures actually give us some insight into adolescent behavior and how to deal with them. First thing is that they are asking for help and we have to give them help. So parents and all the other caregivers need to be need to give help. Second is about balance. So extreme behavior is common in adolescents, extreme reactions of parents and other people is common in adolescents. So balance is important, and we have to be like kites. So kites and extreme. So we have to be like a string to adolescents where we give them enough freedom so that they can fly. At the same time, we can hold on to the string so that they are grounded. Thank you so much.
For giving me the opportunity to speak on the most neglected tropical disease. All of us know that snake bite is the most neglected tropical disease by the politicians, scientists, doctors, and all the things. But all of us should know about the management of the snake bite because it is a disease of the poor. Most of the poor farmers, young farmers, tribal people, children and women are affected due to snake bite. And all over the world there are snakes except few places, few countries like Ireland, New Zealand, there are no snakes at all. In Antarctica, India is the dense forest for the snakes and it is a big habitat, and there are many species of snake in India, more than 275 species of snakes found in India. 62 are highly venomous, but we know only 4 venomous snakes. Highest burden in rural part of the country. In the world, around 5 to 6 million snake bites occurs every year. Out of that, 2.8 million enoming occurs, and 80 to 1,38,000 deaths occur annually. More than 4 lakh people are permanently disabled, means they have to be amputated or there is kidney failure and chronic sequelae. In India, around 2 to 2.5 million snake bites. Out of that, 64,000 deaths annually. And 80% of the global deaths occur in India only. Maharashtra, West Bengal, UP, MP, Rajasthan, these are the highest states. For every 2 HIV deaths, there is 1 death of snake bite. According to WHO, only 10% of the snake bite victims are reported. So the incidence must be higher than this. WHO recently added snake bite in the most neglected tropical disease. Most common risk factors are climate change, seasonal like rains and harvesters, agriculture workers, fishermen, epidemics resulting from flooding. The incidence increases automatically. This is the venomous snakes all over the world, 2,700 species. In India, 275 and 62 are venomous. Most common snakes are viper. 46% are viper and 54% are elapid. Viper means Russell's viper, swasted viper, green pit viper, bamboo pit viper, and elapids mean cobra, crate and coral snakes. So this is our area. I am from Narayangao. Near this place, you may be knowing, 80 kilometers from Pune, north of Pune, and government has built 5 irrigation dams. So naturally land cultivation is increased and farmers are growing different vegetables throughout the year. Naturally, the interaction of human being, farmers and snakes is increased, and incidence is also increasing since last few years. This is the Pune district, Jundar and Ambegaon Taluka. I always mention our region, Jundar and Ambegaon, is a red spot for the hotspot for the snake bite victims. There are 12 deaths in small village in 2014 in one month due to snake bites. So this is high incidence. We must know how to identify venomous and non-venomous snakes. Otherwise, it is very difficult to treat the patients. These are the non-venomous snakes. But medically significant snakes are common krait, that is Indian krait, cobra, Indian cobra, Russell swiper and Swastiated viper. In middle of the slide there is average yield per bite and lethal dose of the venom, and how much venom is lethal for causes the death of the human being. And in krait it is only 6 milligram. Swastiated viper 8 milligram, cobra 12 milligram, and Russell swiper it is 15 milligram. So this is incidence. So venom composition mainly proteins and enzymes and non-enzymatic polypeptide toxins. These are highly toxic. It contains more than 200 toxins in the snake venom. 1 ml of snake venom contains more than 200 different toxins, and each toxin is having different action on our body. This is the fang apparatus of the Russell swiper. You can see the huge fangs, and there is muscle gland and duct. It is just like a hypodermic injection needle. So these are the different side effects of the snake bite, that is neurotoxicity, myotoxicity, platelet aggregation, anticoagulation, microbial side effects, inflammatory, hypotensive, hemolytic and cytotoxic. We are not going into details of all these. Each and every part of the organ of the body is affected within few seconds. So snake bite is a very time limiting emergency. In case of cobra bite, patient dies on the spot after bite. I had seen such patients and know such patients. After cobra bite, patient died on the spot without any disease. So we have to be prepared mentally to treat this patient as early as possible. So this is the pictures of Russell swiper. This is the Russell swiper. Mainly signs and symptoms are shock, collapse and death. Severe local pain, local bleeding, tenderness and swelling, blisters at the site of bite area. The swelling progresses very rapidly in case of a Russell swiper bite. Nausea, vomiting, pain in abdomen, systemic bleeding, all over there is bleeding. Hematemesis, hematuria, subconjunctival hemorrhage, intracranial, intraabdominal bleeding, PTG, purpura, ecchymosis, coagulopathy. In after 4 to 5 days, if not treated properly, then there is anuria and acute kidney failure. The severity of symptoms depends on the age and site of the victim. Rarely there is intra-abdominal and brain hemorrhage. So we have to be very careful. These are some of the signs and symptoms. From bite mark, it is very difficult to identify which snake has bitten. You can see active bleeding from the bite of the site. There is a blister, necrosis, swelling all over the limb, scrotal swelling also. There is local necrosis at the bite of the site, subconjunctival hemorrhage, gum bleeding, scrotal swelling and hematuria. These are the unusual site of the bite. This sugarcane worker had a Russell swiper bite on the neck. This is on the chest. This lady had on the medial side of the thigh and pin of the ear. All these are unusual site of the bite. Most of the bite occur in the lower limbs or on the hands while working in the farm. This patient is very interesting. Russell swiper is usually vascular toxic, but this patient also had a neurotoxicity. So some Russell swiper are also neurotoxic, like cobra bite and krait bite. You can see ptosis. You can easily identify ptosis. If you are seeing patient without any symptoms or without any history, you can diagnose him as a case of cobra bite. But this is not the story. He had a Russell swiper bite. This patient also had a renal failure. See his urea and creatinine raised around 5.80 because he has not received treatment in time and he required hemodialysis also. See the hematuria, huge swelling of the upper limb. This lady had a history of unknown bite, but we diagnosed her as a case of Russell swiper bite, and she was treated with the anti-snake venom and other things, emergency medical management, but she developed necrosis of the finger and we have to amputate the finger. The finger bites, the capillaries are very small, so we are not able to save the fingers. And this lady also had a non-oliguric renal failure. Non-oliguric renal failure means her urine output was normal, even more than normal, but her creatinine and urea is raised. So we have treated only with the IV fluids and electrolyte balance management. I am not wasting time. This is classical viper bite. This patient had a viper bite and see his head. swollen like a viper. So he had also cardiac problems before 2 years before the bite, and he was on antiplatelet drugs, and he had a severe hypertension. He admitted in respiratory distress. We taken him on non-invasive ventilation. His WBCT is more than 1 hour. I will tell you what is WBCT, and we had given him 20 vials of anti-snake venom. Then, after 3 weeks, he also developed hemiparesis. Means in some vasculotoxic snake bite, there is coagulopathy and thrombosis also occurs. This is a Russell swiper bite with cardiotoxicity. This 40 years male had a Russell swiper bite on the great toe and was transferred to nearest PSC within 15 minutes. And they started 4 vials of anti-snake venom. He developed giddiness, chest pain, drowsiness, pain and swelling at the site of bite, active bleeding. His whole blood clotting time is 2 hours. His BP is 80 systolic, but he easily showed arrhythmia and ventricular ectopics also. So all these patients of Russell swiper type, they develop cardiotoxicity as well. They develop arrhythmias, acute myocardial infarction, and they go in shock immediately. So we have treated him as regular management. This is the most complicated patient I have treated of Russell swiper bite. You must listen carefully to the history. This 30 years male was gone in the farm in the evening. He said that he had a thorn prick. After 1 hour, he started complaining pain in abdomen and vomiting. So he was taken to nearest general practitioner. He taken the history and he diagnosed him a patient of acute appendicitis. And surgeon was involved. Surgeon also said get sonography done. Sonologist said that it is McBurney's tenderness, please correct clinically. And he was posted for surgery. But unfortunately, there was not anesthetist available at the night. So surgery was postponed till morning. But early in the morning when anesthetist came and catheter done, she had seen a hematuria. So they suspected something different and he was referred to our hospital. We diagnosed him as a case of Russell swiper bite. The proper history taking is very important. So patient was telling that त्याला काटा टोचलाय आणि नंतर पेन abdomen vomiting सुरू झाले. But he was neglected by general practitioner. So he was not received anti-snake venom in time, and he had all multiple complications, multi-organ failure, bleeding, shock. He had a
Sir, 2 minutes.
Okay, that's 2 cases. Hematuria, marina, all complications, convulsions and everything. So he also required dialysis. This girl also required 5 surgeries and tendinoachilles replacement. So this lady, you can see, we are doing proper wound management and skin grafting also. So we are life saving, and see this girl, old lady, she had also Russell swiper bite. She required skin grafting. She had all multiple cardiac complications as well. So this is a soft-scale viper. This is also similar symptoms. This is a neglected case, and I'm telling you something different. I want to tell you one important thing only. Just give me 1 minute. This is a presentation in Oxford. This is a presentation in Abu Dhabi. This test I want to. Their students are there. This is a simple glass test tube. 2 ml blood is taken in the glass test tube, and tube is kept 2 hours straight, not tilted. After 20 minutes, you tilt the test tube and see whether blood is coagulable or not. And if it is not coagulable, means it is definitely a vascular toxic snake bite, either Russell swiper, soft-scale viper, or pit viper bite. And on this test, this is very important test, diagnostic and therapeutic value also. On this test, we are deciding the dose of anti-snake venom. Anti-snake venom is the only antidote for snake bite. So initially we give 10 vials of anti-snake venom. In this case, if blood is not coagulable for 20 minutes, and repeat test every 6 hourly, and depending on that, we decide the doses. So this is the snake venom detection kit, history, 4 alkaline dialysis. This diagnosis phase, how to diagnose cobra crate, how to differentiate that. Management of kidney failure, management of congestion, coagulation. Sometimes we have to give fresh frozen plasma, platelet transfusion, blood transfusion, etc. Summary is most important. The unknown bite, if any unknown bite comes to you, suspect it as a snake bite, and 24-hour observation is must. Confirmed snake bite, proper history you must take, which snake had bitten at what time taken, what are the symptoms, see signs and symptoms of innovation, neurotoxicity in case of crate or copra white, hematotoxicity due to gallbladder clotting time, renal function test, LFTs. Injection anti-snake venom is the only antidote. In case of cobra and crate white, we have to give 20 vials. Initial 10 vials, and later on, if there is no improvement in signs and symptoms, another 10 vials. Proper wound care is most important. Never refer any neurotoxic bite patient without anti-snake venom and injection atropine and neostimin. Many primary health centers doctors they refer patient of neurotoxic snake bite without ASV and patient dies on the way. And don't give anti-snake venom in non-venomous patients. Clear the airway, ambivag ventilation, if possible intubation and ambivag ventilation. Green pit hyper anti-snake venom is not useful. All this is things. There are many things, but time is limited. These are the patients we have treated. We have treated 5,700 patients successfully without a single mortality. And we have started Mission Zero Snake Bite project in our area, which is appreciated by WHO. I am member of the WHO Snake Bite Committee and many other things. This is the link of our Mission Impossible. All these are the children. So saving lives from snake bite is most important. 4 months child to 80 years old male we have saved. And you can also save snake bite vaccine even though it is very critical, but we have to act immediately. Thank you.
Thank you, sir. I request Dr. Chauhan to felicitate Sadanand Raj. Thank you, Dr. Sadanand Raj, for all the informative sessions. Now I request Dr. Aole to please.
Good afternoon all, and thanks Mastacon for giving this stage to present me on National Tuberculosis Elimination Program. So I will try to brief because hardly anyone is there. So few things just I want to bring to notice that tuberculosis is such an ancient disease, but still huge number of TB cases are there in our country. As per this recent global TB report, we can see that India is contributing almost 28% of our global TB burden. And almost every year in our country, more than 5 lakh people are dying because of this disease, for which we have a very good effective anti-TB drugs also. And recently, India have made a commitment that India is committed to end TB by 2025, 5 years ahead of global SDG target of 2030. Because we are carrying a large number of TB cases in the globe. And these are the actual elimination targets that we have to reduce the incidence by 80%, mortality by 90%. And basically, nobody should face the catastrophic cost because of TB. And that's why actually this session is planned, that wherever patient is going, either in government sector or private sector, all treatment and diagnostic facilities should be available free of charge for those patients, so that they will not have any catastrophic expenditure burden. Yes, definitely there is a progress towards ending TB. There is a decline in incidence, but this is very slow, like 2 to 3% annually. And as per National Strategic Plan 2017 to 25, basically to end the TB, these are some of the important strategies, and one of the very important strategies is private sector engagement. Because in our country, almost more than 50% TB patients are going to private sector, and that's why they need to be involved in the program, and then only can achieve these targets. So basically, program starts from identifying presumptive or TB suspects, and everybody should know what is presumptive TB case, because we need to identify these cases at the earliest and do the subsequent evaluation, then you can diagnose the TB case. So all of us as a doctor, we know that presumptive pulmonary TB is a person with any of the symptoms and signs suggestive of TB, including cough more than 2 weeks, fever more than 2 weeks, significant weight loss, hemoptysis, and any abnormality in chest radiogram. So any such kind of person is there, we need to suspect for tuberculosis, and we need to do subsequent evaluation for that person to diagnose the TB case. So what are the diagnostic technologies available under National TB Elimination Program? We have all the WHO approved diagnostic options available under NTP. So we have leaded microscopy, solid culture, liquid culture, even LED based FM. But the recent rapid diagnostic technologies that are available is one of that is line probe assay. Because this is very important technology for diagnosing drug resistant tuberculosis. And here, without doing any culture, we can directly do the DST of first line anti-TB drugs and second line anti-TB drugs, and we can get the DST result just within 2 to 4 days. And we are using liquid culture also. And we have in Maharashtra almost 12 culture and DST lab which are linked with the program where we are giving the free of charge services to the patients. And in 2010, WHO approved very rapid technology for diagnosis of TB, that is called as nucleic acid amplification test, that is CBNAT or Gene Expert. And here we can get the diagnosis of TB just within 120 minutes, where we can get the diagnosis of TB also, and parallelly we will get a DST of rifampicin also, so that we can decide whether this patient is drug-resistant tuberculosis or MDR or DST, we can start the treatment. So there is no need of doing culture, but directly by NAT we can do. And again in 2020 we got indigenous technology, that is TrueNAT. Here also within 2 hours we can get the diagnosis of TB also, and even parallelly DST of rifampicin within 2 hours. And in program currently we have almost 400 NAT and TrueNAT machines in the field, where we are providing free of charge services to the public sector patients also and private sector patients also. So they can use this facility because almost these tests cost more than 2,000 rupees per test in private sector. So these are available free of charge in the public sector. So this is again, I will not go into that detail. So in for treatment of drug sensitive TB, we have only now one regimen. Previously in program we used to have 3 different categories, but now whether the patient is new or previously treated, only one regimen is there for drug sensitive TB. That is initially for 2 months we use 4 drugs, INS, rifampicin, pyrazinamide and ethambutol. And for continuation phase we have 3 drugs, that is INS, rifampicin and ethambutol. If the patient is DSTB, we use this 6-month treatment. But certain extrapulmonary cases like bone TB or meningeal TB, so this treatment can be extended up to 12 months also, based and depending on the clinician's opinion. And these are the different drug doses we are using in the program as per the patient's weight. And in program we have a fixed drug combination drugs now. It's not loose drugs, but definitely loose drugs are also available wherever there are some ADRs or something. But these are the FDC strips for adults, like 4 drug FDC and 3 drug FDCs. And these are available for both public sector patients also and private sector patients free of charge. And we are not doing milligram per kg doses in program, but it's weight band. Like for adult TB patients, we have 5 weight bands, and as per the weight bands, medicines are dispensed to the patients. Even for pediatrics, we have 6 weight bands, and according to the weight bands, only we are giving these drugs. But wherever it is required, loose drugs that can be used as per milligram per kg body weight. This was about the drug sensitive TB. We are facing challenges with the drug resistance also, and these are some of the definitions. Like we should know at least what is MDR TB. MDR TB is multi-drug resistant tuberculosis, and when patient is resistant to very important 2 drugs, that is isoniazid and rifampicin, then it is called as MDR TB. And extensively drug resistant TB is basically MDR TB plus patient is again resistant to leoflox or moxiflox and any additional group A drugs, that is linezolid or bedaquiline. So if you see what is the prevalence of MDR-TB in our country as per this National Drug Resistance Survey, so in India almost 6% of our tuberculosis patients are resistant to isoniazid and rifampicin. So that's why it's very important to do the DST upfront to rule out the drug resistance, and then accordingly we should start the appropriate treatment regimen. So these are some of the new drugs which are there available in the programs. I think after rifampicin, this drug developed after 50 years, anti-TB drugs. So we have two drugs in the program, that is bedaquiline and delamanid. They are basically used for treatment of drug-resistant tuberculosis. And these drugs are not available in the market. It is available only with the National TB Elimination Program only. So these are the classification of anti-TB drugs to formulate the anti-TB regimens. And for even DRTB, we have only now 3 different regimens. If the patient is resistant to isoniazid, we have all oral H monopoly DRTB regimen, and here the regimen is for 6 to 9 months, and 4 drugs are used, that is levoflox, rifampicin, ethambutol, and pyrazinamide. Then we have a regimen for MDR-TB, that is shorter oral bedaquiline containing MDR-TB regimen. This is basically for around 9 to 12 months, 11 months. And then again we have all oral longer XDR-TB regimen, that is for almost 18 to 20 months. And these are very costly drugs. Almost one MDR-TB course costs 1.5 lakh treatment from the diagnosis to the treatment drugs. Because this bedaquiline itself cost, one bottle for one course cost around 40,000 rupees. And everything is available free of charge from the program to the private sector patients also. Your patients can remain with you, and the program can provide these drugs free of charge for the diagnosis also and for treatment also. Even recently, this one new regimen is under development and operational, that is BPAL regimen, and we are having one more new drug, that is pritomanid. And here the duration is going to be reduced 6 to 9 months only. So even MDR treatment will be around for 6 to 9 months like DSTB only. Even on the front of like this is one preventive aspect, like the contacts of family. If there is an index case who is TB positive in the family, and their contacts should also get some treatment. So now we have some standard regimens for the contacts. We need to screen them properly by doing symptomatic screening or doing IGRA or TST test and rule out the TB disease. And if the patient is not having TB, contact is not having any disease, then we can give a chemoprophylaxis in terms of 6 months isoniazid. Or there is recently one new regimen is available, that is 3 months weekly isoniazid and rifampicin. This is rifampicin is a newer drug now for chemoprophylaxis is being used, and already we have started this strategy under the program. Very important, this was considering the private sector in the gathering. We thought we need to talk more about the private sector engagement and TB notification gazette, because all of us know that TB is now a notifiable disease, and that's why every private practitioner who is diagnosing TB cases and managing, they need to notify the TB cases to the government authorities so that appropriate actions can be taken. So this notification order has already been issued in 2012. Then in 2018, this came in the Gazette of India, and by this it is mandatory for every practitioners, even chemists and drugs and laboratories also, they need to notify the TB cases to the government. Otherwise, there are some legal provisions also in this, like IPC 269 or 270, which has a provisions of even some fines or in terms of imprisonment also if you are not notifying these cases to the public health authorities. And basically objective is to establish comprehensive TB surveillance in India so that we know what is the burden of TB in our country and what can be done in future. So everybody need to register their hospitals or clinics into the Nikshay software, coordinate with your district TB officers and get registered into the Nikshay so that you can start notifying the cases from your clinic or hospital. And either you can notify these cases in terms of real time by using Nexus software, or you can send the reports in this kind of hard copy formats to the district TB officer or identify local health authorities who can take the subsequent public health actions for these patients. All the information of these patients will remain confidential as a public health responsibility. So this is one important slide again. All the free services which are available for TB patients in the government are available for private sector also. In terms of diagnosis by NAT testing, liquid culture, line probe assay, and even anti-TB drugs are also available free of charge. And currently almost 50% of private sector patients are using anti-TB drugs from the program free of charge. And even many of them are using the NAT test from the program also. And for every patient which is diagnosed and on treatment either in public sector or private sector, they are getting 500 rupees monthly as a nutrition support till the end of treatment, irrespective of sector, but they need to provide their bank details and everything, so that can be transferred online. Even a private doctor who is notifying TB cases to the government, they get 500 rupees for every notification and 500 rupees after declaring the outcome. So many, almost 53,000 health facilities in Maharashtra are registered NICSHE, and most of them have started notification. And there is an increasing trend of notification from private sector. You can see from this slide from 2017 to 2022, we have started from 24% contribution from private sector to now almost 45% contribution from private sector. So there is a great support from private sector, and most of them have started this notification. Even there are some interface agencies which are supporting to the private doctors to help the notification. Recently, Pradhan Mantri TB Mukt Bharat Abhiyan has been launched by Honorable President of India, and under this, anybody can become a donor or Nikshay Mitra who can support the TB patient in terms of nutrition, or they can support in terms of diagnostics or any vocational services to the TB patients. And many patients are getting support. Like in Maharashtra recently, more than 25,000 patients are getting supports in terms of nutrition from different donors. There are some politicians, individuals, or some corporate sector, they are supporting these patients. Even in Maharashtra, we have this function under the chairmanship of Honorable Governor. All data in the NTB program is digitalized under this Nikshay software. This is very good application that is called Nikshay Setu app, and under this every guidelines available under the National TB Elimination Program is available. Anybody can download this app and have access to all the guidelines. So you can, it's on the tip of, like, you can get any information like COVID. Even this is the TB Arogya Sathi app, which is good, very good for the community and TB patients. So they can log in and monitor their progress of treatment, whether they are getting DBT or not. So everything can be monitored through this app. So it's time to come together to NTB. So all public and private sector need to join hand together. Then only we can achieve the TB elimination from our country. So thank you. TB Harega, please.
Thank you so much, Lily sir, for your informative session. Now I request Dr. Vikas Golab sir, who has chaired this session, to felicitate Dr. Lily sir. Also request Dr. Ravid Kute sir to felicitate Dr. Lily. Dr. Mayuresh sir and Indranil sir to chair the session.
Good afternoon, everyone. First of all, I thank Dr. Kute sir for giving me the opportunity to talk in this Mastacon Shirdi. I will be speaking on the ocular manifestations in diabetes mellitus. You know that there are two people sitting here, but almost every person, someone related or in the family, there is a diabetic person nowadays. So either yourself you are going to suffer or nearby relatives who are suffering from the diabetes mellitus. So before he becomes a blind, you should know what are the manifestations of diabetes in the eye and how to manage it. First of all, we will see that what is the diabetic retinopathy. The incidence of that blindness is 20 times more than the normal populations. Approximately 2% of all diabetes becomes blind. Commonest cause of blindness is diabetes after 50 years of the age group. Diabetes is related more to the duration of the diabetes than to any other factors. Usually we say that his sugar is more, so he will suffer, but not only the sugar level, but the duration. If it is a 7 years, 8 years, 9 years diabetic person, obviously he suffers retinopathy. Same way he suffers other manifestations like cardiomyopathy as well as renal components also are there. The incidence is 17% in patients who are having diabetes more than 5 years, while 98% patients suffer some sort of diabetic retinopathy at the end of 15 years of diabetes harbor in his body. 34% shows some sort of diabetic retinopathy at the 4th year after he develops the diabetes in his body. So what factors influence the natural course of the diabetes in eye? That is, first thing is age at diagnosis, whether it is a juvenile diabetes or it is an adult onset or type 2 diabetes. Duration of the diabetes is the most important factor, insulin dependent or non-insulin dependent. Then what is his metabolic control, whether it is suddenly controlled or it is a slowly controlled diabetes, whether it is tight control or poorly controlled. If it is uncontrolled or irregular diabetic control, then that person suffers more than the others. If diabetes is associated with blood pressure, renal disease, microalbuminuria, pregnancy, like anemia, smoking, race, then obviously these factors also adds in this microangiopathy, and there is a rapid worsening of the retinopathy. If you want to learn the diabetic microangiopathy anywhere in the body, but maybe it is in the kidney or in the heart or in the brain, you should remember this figure. Here you will see that there are two components. This microangiopathy causes a capillary damage, endothelial damage or basement membrane damage. Once the basement membrane is damaged, then the osmolarity of the blood vessels is lost. That semi-permeable membranes or these membranes will lose out the serum out of the capillaries. So the lipids and lipoproteins will come out of the blood vessels into the interstitial tissue, anywhere in the kidneys, the retina as well as in the blood, and they will start seepaging over there and will cause the edema. Again, this will cause increased stickiness of the RBCs as well as platelet, and they will cause the occlusion, micro-occlusions of the blood vessels. If there is an occlusion of the blood vessels, that area becomes ischemic. If area becomes ischemic, whether it is in the heart, kidneys or in the retina, these are the end organs, end artery organs. That's why these are the very important organs. Then there is no blood supply and the body will start secreting the vascular endothelial growth factor and new blood vessels will grow there. And they are the main culprit for the future pathologies. So what if it is a microangiopathy? That is a vascular disorder. Basically a diabetic microangiopathy is a vascular disorder. Then what lesions you see in the retina? Particularly retina is the only window of diabetic assessment as such, where you can see the retina which is visible. You can't see the blood vessels in the kidney, you can't see directly the blood vessels of the heart or brain. But here you know the blood vessels directly, you can see, and the side effect of the diabetes on the blood vessels and the surroundings. So microaneurysms can be seen, hemorrhages can be seen, cottonwool spots can be seen, hard exudations can be seen, retinal edema is visible and you can see directly with your eyes. Venous changes like venous loops are there, venous bleeding is there, venous dilatation is there, venous tortuosity is there, which are very common in diabetic cases. Then neovascularization of the retina, neovascularization on the disc. Then fibroglial tissue or tissues, fibrous tissue which develops after this microangiopathy, which on contraction causes the changes. Okay, these are the leakages. You can see that if we do the angiography, like what you do in the angiography in the heart or the angiography of the brain, then you see same thing. Here you can see directly on the angiography there is a leakage. The venous bleeding is there, tortuosity is there, there is ischemic area. You see that there is no blood vessel at all here. Then here you can see that there is a leakage from new vessels. These are the abnormal vessels. These are the microaneurysms are there, or small blood vessel amputations are there, and they are leaking the things. All these changes
which started in the retina, you can take the help of these changes and correlate these findings with the renal changes also. They go hand in hand. Same changes in wherever there are the blood vessels. But other parts of the body are not vital organs. Non-vital organs can still sustain, but the vital organs like kidney, heart and retina will definitely need attention to manage it. So if you want to study any disease into thoroughly want to study then the manifestations of this disease. Well, you know that the diabetes is the long-standing disease or chronic disease. Once it is entered into the body, maybe at the age of 45, 50 years, it will remain with you for till you die. So these chronic diseases will not manifest the same way on the day one. So it is classified according to its severity and manifestation, whether it is a mild type of diabetic retinopathy, moderate type of retinopathy, or it is a severe type of retinopathy, depending upon the age of the diabetes, control of the diabetes, and other factors, genetic factors, and others. Then there is a component of diabetic maculopathy, which is also can be divided into various components. And later on, if the disease is ignored, unnoticed, or not taken care properly, it progresses to a neovascular stage that is called as a proliferative diabetic retinopathy, and in which the bleeding occurs inside the eye, in the vitreous cavity, and patient becomes blind. Sometimes it progresses to retinal detachment itself. So we will see that what happens in various stages of the diabetic retinopathy. Here you can see that in a photo. This is the dot hemorrhage. These types of hemorrhages, these are the microaneurysms, leaking microaneurysms. These are the very small. You will see that these microaneurysms are 50 microns. 50 microns, otherwise it is very difficult to see it with the naked eyes. But in the eyes, with the microscopes and with the fundus cameras and angiographic equipment, you can document them very well and give the patient the type of retinopathy, stage of retinopathy, and the management. Same way here you can see that these are small hemorrhages have been started. That is again early retinopathy or mild retinopathy. Why to know these things, this mild retinopathy? Here these are the warning signs or cautious signs. If at this stage, if it is as long as it is a mild or moderate retinopathy, changes are there, they are reversible, or you can delay the progress or slow down the progress of the disease. You may not completely make it zero, but if it is running at the speed of 70, 80, you can make it 10, 15, 20 and prolong the retinopathy changes and prolong the blindness as well as the diabetic kidney disease as well as the cardiomyopathy. Then if it progresses, then obviously you know that this patient has not controlled. So there is lots of oozing of the lipids and proteins out of the blood vessels which otherwise should not come out. You know that the blood or serum do not come directly out of the blood vessels, but because of its homeostasis mechanism. But if it starts, means there is a damage to this mechanism. The endothelial cells, basement membrane of the capillaries are not functioning well. They are damaged somewhere, and that is what they are oozing out the lipids and lipoproteins inside. And that's why there is a hemorrhages and hard exudates everywhere. That hard exudates nothing but the lipoproteins. You can see that everywhere if these are seen. If it is again further, if patient is not under control or it is having the diabetes of 15 years, 20 years, then obviously this microangiopathy or slow poisoning, we call it as a slow poisoning. This changes keeps on progressing and you get these capillary leakages, and the capillary leaks the proteins as well as the blood. Now the blood dots and dot and blot type of blood has been come out of the blood vessels, and this retina is now causing the edema. Here you can see that if anything which is oozing out will cause the seepage, or there is an edema or a thickening of that tissue, and it persists for a longer time. If it persists for a longer time, you can see that this hard exudates and all. These are the clumps, or you can see the hard exudates, crystals are formed there. That means it is damaging the very delicate tissue of the retina. If it is damaging, means it is not functioning properly. Its function is a neurological tissue. Retina is a neurological extension of the brain. If it is not functioning, means you will get the blindness, or your vision is being disturbed and quality of vision is being disturbed. Same thing if it is a severe type, you can see that there is a hard exudates, cotonormal spots. Cotonormal spots shows, indicate that there is a ischemic insult. Ischemic insult means that capillary is stopped perfusing over there. So that particular area has become dead. If such types of more and more areas are there, then obviously the function of that tissue will be decreased and patient will slowly become blind. Here you can see that there is a capillary dropout, there is no capillary. Here there is a new aspiration and these are the new vessels forming which are leaking away. Here also you can see that this blood vessel is a new one. New blood vessels do not have all three layers, intima, media and all those blood vessels. So it won't hold the content or the fluorescein dye inside. So it is leaking more profusely and coming out. Otherwise you can see that there is the dye. This whitish thing is the dye inside, fluorescein dye, but it is not coming out. It is coming out from the abnormal blood vessels only. Same thing, you can see the changes are there. You can see that the loop formation is being formed. Here the blood vessels or venous looping is there, blood vessels are damaged. Here again you can see that these all capillaries are being lost in the diabetic process or microangial process. This venous bleeding is there and tomorrow this beaded blood vessel will cause occlusion. What happens in thrombosis and all those varicose veins also. Slowly the thickness of the blood vessel increases and one fine day it causes the obstruction. Here you can see this obstruction has been occurred and there is a threatening. There is no blood into this blood vessel. You can see the white blood vessel. Here you can see the normal blood vessel and these are the occluded blood vessels. Whitening has been occurred. So if this stage again further progresses, then the patient goes into the proliferative stage. The body has been now identified that there is ischemic changes. So it starts secreting vasoproliferative substances in demand that now I am in a need, I am hungry, send something. So body try to develop new vessel. But you know that after birth means after 9 months and 9 days, your organs or nothing has been developed, new organs never created, only size has been increased. You can see your childhood photo and today's photo. Your size is increased. Thus there is any increase in your number of the organ, nothing. You are 1 year, 1, 2 eyes, there is no increase or no addition of single blood vessel also. So whatever it is found is called as an abortive effect of this body to help out in the situation, and these new vessels are abortive and they are abnormal. You can see here there are the abnormal blood vessels have been developed in the demand. The body tries to develop vasoproliferative substances, they develop the small new vessels, and these new vessels do not have all layers, and with the little bit of the stress they bleed. Here again you can see this leakages from these blood vessels. Here you can see this is a capillary dropout area. Sometimes there is a collateral formation, which collateral formations means beneficial effect, but if new aspiration is there, that is a bad effect. And these new vessels obviously everywhere will keep on developing the fibrovascular tissues on the retina, and retina is a very delicate, its thickness is almost 300 to 400 micron. Only 300 and 500 micron thickness, and it is a fragile tissue. If the fibrovascular tissue contacts, it causes the detachment of this tissue and it again loses the function. Here also you can see that there are new vessels have been formed. Again there is a bleeding from these new vessels with a little trivial stress. If you are having constipation and coughing and all those things, lifting the heavy weight or running, then these blood vessels will ooze out and come out, the blood will come out. If it is a small quantity, nothing much to worry. But if it increases, then you can see that the bleeding increases, the patient becomes blind. You cannot see through this blood. This blood film is in between you and the picture. So it will not allow you to see the pictures properly and they will be abnormal. Here again you can see that lots of bleeding has been occurred from the new vessels. And here you can see the sclerosed vessels. These vessels, vascular occlusion. Why it is important to study is that you correlate again. The cardiac vascular surgeon, he knows that. If someone is there in the urologist or neurosurgeon, he also will see that these are end organs. If the blood vessels are blocked, obviously that the tissue is dead. It is not functioning, and again it is abnormal. Same thing here. These are the changes. Here you can see that so much of the capillary dropout. There is no blood vessel at all. So small capillaries are absent. You know that there are arteries, capillaries, and veins. There are capillaries are absent completely, and the bleeding has been occurred. This is called as a proliferative diabetic retinopathy, and various stages are there. If the disease progresses, means it was this fibrovascular tissue was yes, okay. And this fibrovascular tissue will detach the retina, and there is so many bleeding again. You can capture these types of changes with the OCT. These are the optical biopsy, not a tissue biopsy, on which you can see how much of the edema is there. You can see that there is so much of the fluid is being collected there, and fluid is collected from this oozing. This is called a diabetic maculopathy. Various types of maculopathy. You can see that fat tissues are coming out, and patient's reading writing vision is lost. Whereas you can see that this is so much of the losing from this one, and there is the edema, and patient's quality of vision is now no more. Here again you can see that there are so many microorganisms which are leaking and causing the edema. Here again you can see in this picture, these are the varieties of the patients we have collected, and various presentations. In all these presentations, patient has lost the capillaries, and this is a normal vasculature, and you can see this what happens in ischemia. There is a loss of the capillaries, which can be picked out on the angiography as well as OCT angiography without that. And these are the hard exudate crystals, and patient has lost the vision. Here even the OCT is nowadays, which will give you the exact status of the retina and what will happen after treatment. After treatment also you can see what is the stage. If you come across with such types of diseases, then how to treat? Either you have to do with the laser is one modality, then injection is another modality, and surgery is the last modality. Or you have to do the mix and match. Here you have given the anti-VEGF injection, that is vascular endothelial growth factor injections against that, and the edema has been come down. Same way here also we have given injection, and after injections the edema has come down. Here also you can see these pictures, pre-treatment and post-treatment. Here then if it won't work, then obviously you need to do the surgeries. Here this is a pre-surgery, and this is picture which is a post-surgery. Here again you can see that above two pictures are before surgery and below two pictures are after surgery. Here again this picture is pre-surgery and post-surgery. So there are other components like mixed hypotension and diabetic retinopathy. This is a renal retinopathy. Then this is hyperlipidemia. Yes, this is hyperlipidemia and all this. Then other manifestations in diabetes, you get the infections in the cornea. The patient gets debilitated and get the endophthalmitis, that is infection inside the eye. If you don't treat it properly, then the patient develops the lateral eye detachment, blindness because of hemorrhage, and that is a burden on the society. In conclusion, you need to identify the stage of the diabetic disease, do the proper counseling, refer the patient properly in time, and if you do the treatment in time, in my experience, no one go blind. That's all. Thank you very much.
I request Dr. Prashant More sir.
Good afternoon everyone. I am Dr. Pranali Trimukhe. I am consultant pulmonologist from Ahmednagar, and I am practicing there since last 2.5 years at Trimukhe Heart and Chest Super Speciality Hospital. After the era of this SARS-CoV-2 pandemic, everyone has been aware regarding the respiratory care. Nebulization therapy is very commonly utilized mode of drug administration, which has been commonly used, but most of the time it is misused. So there are certain Indian guidelines has been established this year, and we'll discuss regarding them thoroughly. So inhalation therapy today, it is the mainstay of the treatment for obstructive airway diseases. Apart from this, there are many non-pulmonary disorders which are now establishing for this use of the route. The inhalation therapy commonly prescribed through pressurized meter-dose inhalers, dry powder inhaler, and in the nebulization form. So, when to drop these MDIs and DPI and start nebulizing these patients? Commonly, when these patients who are having obstructive airway diseases are presenting with low peak inspiratory flow rate and who are unable to use pressurized MDIs as well as dry powder inhalers, they are the ideal candidate for initiating the nebulization therapy. As we see, obstructive airway diseases are commonly seen among the elderly patients who are very difficult to educate about the coordination of PMDIs and spacer, as well as in pediatric patients it is very easy to administer the nebulization as compared to DPI and MDIs. In cases of severe asthmatic attacks, the supplemental oxygenation along with nebulization will be more helpful. So those will be the ideal candidates to initiate with nebulization therapy. So which kind of nebulizer should be used? So generally there are three types of nebulizer. That jet nebulizer, which uses the compressed gas or compression mechanism has been utilized to create the aerosols. Whereas the ultrasonic nebulizers, they utilize the high frequency ultrasonic waves to create the aerosols from the liquid. The mesh nebulizers utilizes a fine copper network mesh to create these aerosols. When we see the comparison among them, the jet nebulizers are more commonly prescribed nebulizers, but the portability and the carrying them at every possible way is very limited because they require the continued electric supply for using. As compared to the jet nebulizers, vibrating mesh nebulizers are very portable and handy. They can be carried out in bag. Also can be used in air traveling. They are electric as well as battery operated. So, but because of the cost efficacy, the jet nebulizers are most widely preferred nebulizer. So after the type of nebulizer, there are different interfaces to be used while nebulizing the medication. The common are the mouthpiece, the other as the face mask, nasal mask, pacifier mask are commonly used in pediatric or neonatal conditions. High flow nasal cannula and the hood is commonly used in critical cases. The mouthpieces allow for the effectively drug delivery as compared to the face masks, and they should be preferred. So what are these recent Indian guidelines on nebulization therapy? We'll see according to the indication. That is what they say in case of obstructive airway diseases and how to nebulize these patients who are in intensive care unit. What are the indications and guidelines regarding the maintenance or home nebulization and the very special case scenarios like COVID-19. Nebulization therapy in obstructive airway diseases. We'll start with asthma. Asthma is the very common obstructive airway disease, preferably seen among the younger age group. So in asthma, the nebulizer generally used during the acute severe asthma attacks. So which will be the drug of choice to nebulize this patient? The nebulized salbutamol will be the drug of choice, and we can nebulize this patient with 2.5 to 5 milligram every 20 minutes for next 1 hour till the exacerbation subsides. Or alternatively, nivosalbutamol can also be used for the severe asthmatic patients to relieve their exacerbation. Bronchodilators, the indications for the use of bronchodilators in asthma. In acute exacerbation, short-acting beta agonists, just like we have seen the salbutamol, are recommended to relieve the exacerbation. But in case of maintenance therapy, the long-acting beta agonists like formoterol or arformoterol are recommended along with the corticosteroids use for the rapid onset of usage as well as convenient dosage in twice-a-day form. All nebulized short-acting beta agonists with or without short-acting muscarinic agent or long-acting beta agonists should be combined with inhalational corticosteroids in case of asthma. The alone use of short-acting beta agonist or long-acting muscarinic agent or long-acting beta agonist has been discouraged because there are many chances of reflux exacerbation after the use of alone these medications. So where do these inhalational corticosteroids stand in this nebulization form? Even though the guidelines do not recommend the use of corticosteroids during the acute exacerbation, but many of the studies has been established their efficacy to relieve these exacerbation symptoms. Because in asthma there is a severe level of inflammation, and these inhalational corticosteroids will help us to elevate these inflammatory symptoms. The other form of obstructive airway disease, that is chronic obstructive pulmonary diseases like COPD, which can be smoking or non-smoking form of COPDs. The short-acting beta agonist or short-acting muscarinic agent are recommended to relieve the episodes of acute exacerbations. The nebulized form of formoterol or arformoterol is strongly recommended along with these recent GOLD guidelines to use in the long-term manner. This can be used in combination with glycopyrronium, which is a safe and new long-acting muscarinic agent. The combination of arformoterol with glycopyrronium has been established to be more efficacious and convenient combination to maintain these COPD patients who are now relieving from acute exacerbation symptoms. Apart from obstructive airway diseases, the critically ill patients who are difficult to maintain their airways, who are requiring invasive mechanical ventilation, the nebulization of various different medications like anti-inflammatory agents or surfactants, vasoactive agents, mucolytics has already been found to be useful. For these patients who are already on invasive mechanical ventilation, vibrating mesh nebulizers are strongly recommended. And for nebulizing this patient, the semi-recommended position with the elevation of 20 to 30 degrees from horizontal position should be encouraged. Nebulization sometimes can be used in palliation to relieve the symptoms in case of malignancy and other advanced lung diseases, where furosemide or adrenaline, mucolytics, bronchodilators, and steroid can be used. Nebulization of amikacin also been recommended in cases like cystic fibrosis or difficult to treat non-tuberculous mycobacterial infections, along with the supplementation of other multi-drug therapy. Nebulized ribavirin also be seen to be useful in treating these, especially pediatric patients who are having respiratory syncytial viral infections. So what are the recommendations for using this nebulization therapy in COVID-19 era? So viral infections like SARS-CoV-1, SARS-CoV-2, MERS and other contagious infections, they preferably or commonly transmit through the droplets. The droplets which are light-sized particles, whereas the droplet nuclei which are small-sized particles, they get transmitted from the patient, and commonly the healthcare worker can get infected during the nebulization. So minimum distance of 3 to 6 feet should be maintained to avoid the contact with the droplets, whereas the use of N95 mask should be encouraged to avoid the droplet nuclei infection. Aerosols generated during these aerosols generating procedures such as intubation, bronchoscopy, or suctioning on patients who are on mechanical ventilation can lead to the acquiring these infections in healthcare providers. But in case of nebulization, the particles generated are at the size of 1 to 5 microns, and that can potentially carry the pathogens from the lung. So however, the role of transmission has not been certain, but the precautions have been recommended while nebulizing these patients who are having COVID-19. The strong recommendations are like patients should be nebulized in isolated rooms, minimum healthcare workers or minimum access to be kept to the other visitors to such rooms. The next is the maintenance nebulization. Once we see our patient with severe COPD or severe asthmatic patients, they get hospitalized and now they are getting improved, how to discharge them? Many of these patients still do not improve their peak expiratory flow rate, that they can be shifted to beta-dose inhalers or dry powder inhalers. So many of these patients may require domiciliary or home maintenance nebulization. The home maintenance nebulization patient should be thoroughly counseled regarding the proper use of this nebulizer therapy, regarding the cleaning, disinfection, storage and maintenance of it. the regular assessment of this patient, that is every 15 days in the first month, then every monthly after 6 months, and then as and when required should be encouraged, because there is a high dose of medication already has been administered via nebulization. So patient is requiring when more than 2 weeks the regular interval of how properly patient is using these medications, how symptoms are getting relieved should be made. And every effort should be made to shift this patient from nebulization to other mode of inhalational therapy, that is use of PMDI spacer or DPI should be made. So in crux, what are these correct way to use this nebulization? The ideal aerosol diameter recommended to provide this nebulization therapy are between 3 to 6 microns, because those particles who are generating more than 5 microns, they deposit into the level of nose and mouth only. But those are varying between 2 to 5 microns, they'll get lost into the tracheobronchial deposition, whereas the very fine mist molecules which are varying between 0.5 to 2 microns, they'll definitely deposit to the alveolar cavern. But those are very fine, they get deposited into the lung thoroughly, but the larger molecules have greater bronchodilation activity. So generally the drugs available in the nebulization
2 minutes
are in the two basic forms, that is the respules and respiratory solutions. Respules are do not require any dilution, are very easy to use, less chances of contamination. Whereas the respiratory solution, there is high risk of contamination, they need to be diluted with the normal saline, and excess dose can be administered with the respiratory solution. So the ampules or respules should be encouraged. So awareness among the patients, paramedics and practitioners is necessary for the good nebulization practices. Pre-nebulization, hand washing, ensuring the device is clean, and ensure the adequate protection for a healthcare worker has been given. In case of infectious cases, nebulization should be done. During nebulization, the mouthpiece should be preferred over the face mask, and separate room or negative pressure room should be created for nebulizing these patients who are having infective respiratory conditions. Post-nebulization, cleaning and disinfection of nebulizer as well as cleaning the surfaces of the room are very necessary. Key aspect is the amount of nebulization liquid given has to be between the 2 to 4 ml, because commonly used jet nebulizer, they always have some residual amount of drug get lost into the respiratory cups. So to give the maximum amount of medication to the patient, the volume has to be more than 2 ml. The normal saline can be used for dilution, but the water should be avoided because that can increase the chance of paradoxical bronchospasm. While mixing these drugs used for nebulization, compatibility and their stability things should be kept in mind. Like we have already discussed, the precautions before nebulizing the infectious patient, the adequate protection should be provided to the healthcare worker, and the all hygiene practices are always encouraged. Patient should be in upright position, breathing deeply. When patient need to be cuffed or take out the phlegm, should be stopped with electric supply of this nebulizer. It is necessary to tap over the nebulizer cups so that the larger amount or larger droplet should get settled and maximum drug can be get utilized. So this is evidence-based study that shows the mouthpieces should be preferred over the face mask. So post-nebulization cleaning, after every use, the mask has to be used. It can be used with running water or detergent. Every weekly, the nebulization
20 minutes are done.
Should be disinfected with the hydrogen peroxide and isopropanol, and should be kept for dry air.
Hello. Good afternoon, all of you. especially want to thank Dr. Putte sir for giving me opportunity to talk on a topic of peripheral vascular disease and recent advances. I am practicing as a vascular surgeon at Aurangabad. So today we are going to talk about peripheral vascular diseases and so what is peripheral vascular disease? So normally if there is any disorder that affects the blood flow through the arteries and veins of the peripheral circulation, it leads to peripheral vascular disease. It mainly affects the legs as compared to arms. Now the peripheral arterial occlusion can be of two types. It is acute and chronic. If there is a sudden arterial occlusion, there is a profound and irreversible tissue ischemia that leads to a lot of death of a tissue and patient will land into amputation. If there is a gradual occlusion, the collateral formation is there, and what happens, tissue gradually adapts to this chronic obstruction and tissue ischemia is less. Now the changes of chronic ischemia can be seen after the physical examination of the patient, like skin is shiny, there is a loss of hair in the extremities. If you examine the nails that are thickened and ripped, and if it is a severe obstruction, it leads to gangrene. In some patients there is an ischemic ulcer, as you can see in these two pictures. There is a chronic ischemia, chronic peripheral arterial disease, and which has led to the gangrene of the toes. Now the classic symptoms of the PED is claudication, that is pain while walking, and it resolves after rest. Now if there is a severe obstruction and ankle brachial index is less than 0.5, so it leads to the rest pain, that is forefoot. It is seen at night and it decreases in the dependent position. On physical examination, you palpate the pulses. In patient of peripheral vascular disease, we are not able to palpate the pulses. Our pulses are very weak, that is femoral, popliteal, dorsalis pedis artery and posterior tibial artery. Now the complications of peripheral arterial disease, it leads to non-healing ulcer, and if tissue ischemia is more, then it leads to death of tissue and gangrene may occur, and if patient lands into the amputation. Now, what investigations lead to the diagnosis? Color Doppler is a very economic investigation, and it tells about the site of the obstruction, it tells about the severity of the obstruction, but it is a subjective test. So the variation may be there from person to person. So other test, that is CT angiography, that gives the exact picture of the occlusion in the lower limbs, the type of the occlusion, whether it is 100%, that is total occlusion is there, the site of the obstruction. We can also do in a cath lab, that is catheter angiography. Both CT angiography and catheter angiography are both standard in the diagnosis of peripheral arterial disease. Now treatment mainly consists of open surgery and interventional surgery, that is endovascular surgery. So in open surgery, we do the peripheral bypass surgery. Depending upon the type of obstruction and the severity of the obstruction, if there is a long segment occlusion and 100% occlusion, sometimes we take the decision of doing bypass surgery. So different bypass surgery is done, that is aortobiofemoral bypass surgery, femoropopliteal bypass surgery, axillobiofemoral surgery, cross-femoral bypass surgery. And we at Aurangabad doing these surgeries regularly with outstanding results. This is the patient having the SFA long segment occlusion, superficial femoral artery. In this patient, we have done femoropopliteal bypass surgery, and this leads to the good flow into the distal vessels in his lower limb. We have used, you can see this picture of the patient having gangrene of the great toe, that is amputated because of the gangrene, and that ulcer was not healing. And the main problem in these patients is that these patients are in severe pain, that is very intolerable pain. Patient is not able to sleep throughout the night, and this patient sits on a bed hanging their limbs on the side of the bed. You see a lot of patients this, and these patients treated properly, these ulcers can heal and the limb of the patient also can be saved. Now the other option is minimally invasive, that is endovascular surgery, peripheral angioplasty. We can do balloon angioplasty and stent angioplasty. This is a patient having superficial femoral artery occlusion. You can see in the picture that in the made SFA is occluded. We have done the balloon angioplasty, and you can see in the third picture that the good flow is seen in superficial femoral artery. Now the post-op pictures are there. The ulcer is completely healed after revascularization of the patient. If doing angioplasty, balloon angioplasty, if there is a dissection of the artery, or if sometimes this artery doesn't open completely, in that case we use stents. So different types of stents are available. Nowadays vasculomimetic stents are available that are very durable and helps patient to reduce symptoms and helps in survival of the limb. Now this is the patient having subclavian artery occlusion. We have done the balloon angioplasty, and post angioplasty good flow is seen in this patient. This is other patient having severe pain, suffering from sole ischemic ulcer which is not healing, was in severe pain, and because of that his quality of life affected. You can see there is a short segment lesion in superficial femoral artery. We have done the balloon angioplasty there, and after angioplasty the ulcer is completely healed. You can see the scab on the ulcer in the next peak. Now these are the definitive treatments, that is peripheral bypass surgery and angioplasty. Other treatments are also available, that is chemical lumbar symplectomy and prostaglandin therapy. The patient selection is very important. Which patient needs which type of treatment. Suppose patient having very diffuse disease, patient is old, debilitated, not fit for any surgery. If he is having long segment occlusions, very diffuse disease, and any intervention is not possible, in that case we have an option of doing chemical lumbar symplectomy. Previously we used to do it by open surgery, but nowadays with a single use of only spinal needle prick we can do lumbar symplectomy. That this helps by vasodilatation and it helps in the ulcer healing. Patient having severe rest pain, diffuse disease, those patients non-operable. We have done around 150 chemical lumbar symplectomies in last 2 years and with very good results. The patients who were advised amputation somewhere, their limbs can be saved with multiple modalities of treatment. Now the prostaglandin therapy, the alpostine is available in the market, and we can use prostaglandin in the patients who are not fit for surgery, having diffuse disease in which any intervention is not possible. So the medically unfit patient having diffuse disease, surgery or angioplasty not possible, in these patients we can give prostaglandin therapy. Now the exercise has very important role in the treatment of peripheral arterial disease, because after treating the occlusion the chances of recurrence are there, and to prevent recurrence the patient should be well counseled and motivated to do exercise regularly. Walking is the best exercise. We advise patient to walk more than 5 kilometers a day, and if he abstain from the tobacco and smoking, most of the patients do well post-operatively. So tobacco use, some of the patients who are not careful about their health, in these patients, even after taking care of their disease, this patient after relieving of their symptoms starts again tobacco use. So in this patient the recurrence rate is high and amputation rate is also high in this patient. Now in our country, as there are the illiteracy rate is more, and particularly bidi smoking is commonly seen in the rural areas. So in these areas the Berger disease, that is thromboangiitis obliterans, is commonly seen, and this is small and medium vessels are involved in this disease. So in this patient chemical lumbar symplectomy and prostaglandin therapy helps a lot, and we can save the limbs of this patient. Now the COMPASS trial has been done about the post-operative treatment with antiplatelets. If we use rivaroxaban, that is Novavax 2.5 mg BD plus ecosprin, the chances of the amputation decreases over a period of time. We can also use clopidogrel plus ecosprin, but the COMPASS trial and other Voyager study, both these trials has proved that the efficacy of rivaroxaban plus ecosprin is better. And the bleeding tendency is also less with this combination. Now, if the patient comes in acute limb ischemia, there are the 6 P's, that is patient having pain, pallor, pulselessness, paresthesia, paralysis and cold extremities. So in this patient, the obstruction is acute. And in acute obstruction, the tissue loss is more, patient led to the amputation if emergency treatment is not given to the patient. So goal of the therapy is to remove the thrombus or embolus as early as possible. For these patients, we can do percutaneous catheter-directed thrombolysis, and we keep the catheter into the artery for 24 hours in the clot so that it dissolves slowly.
So 2 minutes left.
Yeah. So we use retiplase, tenecteplase and altiplase in this patient. We can also do embolectomy in the patients, and embolectomy directly helps to remove the clot from the vessel. So basically, other topic is varicose veins. So I have because of the paucity of the time, we will only discuss about the peripheral arterial disease. And in short, we will see varicose veins. In varicose veins also, the newer modalities are available. Minimally invasive therapy. I will show you some cases. This patient with varicose veins came from Jalgaon. He was having venous ulcer in our limb, and you can see all his ulcer is going up to the scene of the tibia. So after doing the laser treatment of the patient and compressive therapy, this ulcer is healed. This patient, you can see they are having the maggots in the venous ulcer. So after laser ablation of the varicose veins and compression therapy, the ulcer is completely healed. This patient came to Aurangabad from Pune. This patient was suffering from non-healing ulcer since 4 to 5 years. Has visited a lot of hospitals but not getting any results. In this patient, with judicious management, you can see in the third picture the ulcer is completely healed. This patient came from Nagpur. He was having venous ulcer in his lower limb since 4 to 5 years, having severe pain. So in this patient, we have combined the treatment, that is laser ablation plus foam sclerotherapy and 4-layer bandage. And in 2 to 3 months, this ulcer completely healed. In the last picture, you can see the healed ulcer. Nowadays, we can also do the glue therapy for the varicose veins. The laser ablation is a minimally. It is done only through the puncture of the needle, and in laser ablation we need to do intumescent anesthesia around the vein. And in glue therapy you don't need to do intumescent anesthesia, so no multiple pricks of the needle are there. We can use the cyanoacrylate glue, and Venasil and Turkish glue is available in the Indian market. This is also very less painful daycare therapy for the varicose veins. Thank you very much. Hello. Which injury?
Any acute injury, arterial injury. Like I am an orthopedic resident.
Okay, okay.
Frequently or sometimes.
Actually, there are some studies which have shown that there is a role, but basically, if there is any arterial injury, the flow should be restored as early as possible. If there is an arterial injury, basically, I deal with a lot of orthopedic patients. They have concomitant vascular injury, particularly the patients who are having the supracondylar fracture. In this patient, the brachial artery, there is a most of the time that went into the spasm. So, in relieving the spasm, it may have role. But if there is an open injury or if there is a thrombus, the open surgery, that is, you have to remove the thrombus, and if there is rent in the vessel, you have to repair that rent. If after post-operatively it has a role, but the basic problem is that we have to deal with the vascular injury which is there dealing with the orthopedic trauma.
Thank you.
For intimal injury, like knee dislocation.
For vascular. Basically, sir, catheter angiography will be the best, because it can be injury. Catheter angiography will be best because in the same setting we can do the intervention, sir. CT angiography is also the best investigation, but it takes time, and time is very important in case of vascular injury. If time lag is more, and if tissue is already having the pre-gangrenous changes, it becomes difficult to save that limb. So in any injury, the catheter angiography in the cath lab not only help in the diagnosis, and in the same setting, patient having any injury, we can do some intervention also. Thrombus, we can do intravascular thrombolysis, and if patient needs any surgical intervention, can be shifted into the, if patient is having the hybrid OT, we can do the surgery in the same setting. So that will help, sir. I think.
Thank you, sir.
Will be better.
Sir, due to time constraints, I request the audience to.
Yes, it should be done within 6 to 8 hours. But sir, we have seen even after a patient presented after 24 hours, we have repaired their vascular injuries and many limbs have saved. 6 hours, the chances of the survival of the limb increases. But sometimes what happens, patient reaches late from the periphery. So in the next day, even if we do early intervention, the chances of survival are there. Not in 100%, but most of the limbs can be saved. Thanks.
Thank you, sir. I now request Dr. Rajendra sir to please felicitate Dr. Prashant More sir.
Organizer of the Mastacon 2022, Dr. Kutte sir, and the whole organizing committee who is working very hard to make this program successful, and all the delegates, all the respected delegates. Myself, Dr. Zahir Abbas Shah, I am attached to Kadam Medical College, GU's IIM Medical College. I am a MSc accredited speaker and I have spoken at many state and national level. So without wasting much time, I will start with the talk. So before we start the talk, I request all of you to put your mobile on silent mode. As this is the last session, I will not take much time, and I assure you that I will not bore you with the barrage of slides. Don't worry about that. So I will try to cater to practical knowledge. Whenever we talk about the mucus management and mucoactive agents, so before that we have to understand the physiology. Whenever we talk about this physiology, so this mucus is secreted by the mucus gland, and with the help of this mucociliary clearance mechanism, before this mechanism comes in action, there are millions of cilia are there, and the respiratory system is lined with the millions of cilia. So how it functions, I will tell you in the next slide. So these are secreted by the goblet cell, and lungs native immune mechanism is there. So whenever any foreign particle, dust, or any microbes comes in contact with the respiratory system, it is trapped. It is trapped by the mucus flow, and it is expelled out with the body's protective mechanism. So in this slide, this is the figure of cilia. This is the microscopic picture, and this is 9x2 microtubule doublet structure. So the beauty of this cilia is that the millions of cilia are there, and they beat anteriorly and forward continuously, and they beat at the frequency of 12 Hz. And the beauty of the nature is they, without touching each other, they beat continuously anteriorly and forward. It is we destroy these cilia, this nature's gift, with smoking and other things. We destroy this. So whenever there is a mucociliary destruction is there, this whole mechanism is disturbed. And these cilia, this is the 9x2 microtubule doublet is there. It is connected in the center microtubule with the help of this radial spoke, cycle wheel spoke or motorcycle wheel spoke like structure. These are radial spokes, and together with each other with dynein and nexina. And here a microscopic picture of the cilia is there. So to understand this is most important. So mucus flow will be there, mucociliary clearance will come into action, and whatever the trapped microbes, dust will be there. It is cleared out with the help of this protective cuff mechanism. Then what happens in this excessive? What is the cause of excessive mucus production and associated complication? So there are changes in the rheological property. So rheology is nothing but a branch of physics that deals with the deformation and flow of the matter. Number two, whenever the mucociliary clearance is hampered or disturbed in such diseases, cystic fibrosis, bronchiectasis, or other diseases, or ineffective cuff mechanism is there, ineffective cuff mechanism due to old age or any neurological diseases, so that will cause this ineffective reflex mechanism. Now infection and inflammation, this vicious cycle goes on repeating, and they have disturbed this mucociliary clearance. Airway obstruction in the form of obstructive airway disease, it could be bronchial asthma, or it could be COPD, or it could be any other thing. Post-tuberculosis COPD, post-tuberculosis sequelae. After the healing of the lesion, this fibrosis or fibrocavitary disease will obstruct the airway, and it will hamper this because clearance. So parenchymal damage could be there, and that parenchymal damage in the form of cystic fibrosis, that will again hamper. So this vicious cycle is there. So to understand this picture, this inflammation is there. Here the inflammation. First thing, here the initial infection. Whenever the body has this initial infection, inflammation will be there. So severe, there are several chemical mediators like this chemokines, cytokines are there, and they are released into the in the circulation. This will lead to the inflammation. And number two, there will be impaired mucociliary clearance. Airway mucus hypersecretion will be there. This airway obstruction will be there. Microbial colonization. Whenever this microbial colonization, so whenever this bronchus is there, if the lumen gets narrowed down, and there is a repeated infection, the colonization of the bacteria. So to make this session little bit interactive, which are the organisms that are responsible for acute attack of anything, acute severe asthma or acute exacerbation of COPD, anybody? Because you are practicing and you are more related with the patient. We call it as attack of asthma or attack of COPD, anybody? So the organisms are Staph aureus. Staph aureus is there, H. influenzae, Staph aureus, and Moraxella catarrhalis. These are the three main culprits. They are colonizing the lumen of this bronchus. And lastly, there will be bronchial dilatation of the airways and destruction. So this is the vicious cycle that goes on repeating. Inflammation, damage, chronic infection, obstruction, and disorder breathing. Now, coming to the next slide. Okay. So this is nothing but the acute bronchiolitis. So whenever I have to talk about this bronchiolitis or bronchitis, to differentiate, whenever you have to differentiate, bronchitis is the inflammation of the main principal bronchus, and bronchiolitis is the smaller bronchioles are there. And the symptomatology is the child will have runny and stuffy nose, coughing will be there, and the child will be febrile, and wheezing will be there. In the management part of this acute bronchiolitis, this Wang Clinical Severity Code, as per this Wang Clinical Severity Code, they have suggested that the chest physical therapy, hypertonic saline, and prolonged expiration technique is important. Now I will move on this bronchiectasis, which we come in contact very frequently and in our day-to-day practice. Whenever we come in contact with any patient who is a treated case of tuberculosis or due to any disease or childhood infection, we come across this bronchiectasis. So by definition, it is permanent dilatation and destruction of wall of the terminal bronchi. If you see here, this smooth muscle cells is there, coating, goblet cell is intact, cilia are intact, and the wall of the bronchus is intact here in the normal bronchus. But here, there is a destruction of the wall of the bronchus is there, and the ciliary coating is lost due to this bronchiectasis. So bronchus is the tube. It is a Greek word. Bronchus is the tube, and ectasis is stretched out like this. So there will be mucus plugging will be there. So what are the type? Cylindrical type. Cylindrical or tubular are one and the same. Circular or varicose. Varicose veins we come in we frequently hear this word. So varicosity. So here the bronchus will be varicose, irregularly dilated. There is tubular will be structure will be tubular, and cystic. It is a simple cyst-like or rounded structure will be there. So this is a bronchiectasis. So what happens? So the bronchus and the artery, bronchial artery, they are in close contact with each other. But the diameter of each other become the same, and there will be signatoring pattern. So this is the dilated bronchus, and the jewel will be the bronchial artery. So that's why this HRCT picture, it will give rise to signatoring pattern. So if you see this, so there will be segmental bronchus, subsegmental bronchus, and bronchioles are there, terminal bronchioles are there. So there is a destruction of the bronchiole in this. Again in this picture, if you see, we frequently come across this picture. So this is nothing but the bronchiectasis. So if you see, if you do the HRCT test, there will be cystic type of bronchiectasis, and that will give rise to give the picture of signatoring pattern. So this is healthy bronchus, inflamed bronchus, bronchiectasis. Again, here this lung is normal or healthy, and this is bronchiectatic lung. Okay. Now what is cystic fibrosis? So it is nothing but an inherited disease which affects the lung, which is responsible for the destruction of the lung parenchyma along with the other system like sinuses and GI system. So what happens here? In short, I am telling you, whatever secretion we have, it is thin and slippery. But in cystic fibrosis patient, this thin secretion becomes thin, and there will be mucus plugging will be there, and the patient is unable to cough out the secretion. So that endangers the patient's life, and that for that we have to treat this underlying condition. So mucus hypersecretion we are talking about, it plays an important role, and it is important pathophysiological and clinical manifestation of these all. Acute bronchiolitis, bronchiectasis, and cystic fibrosis. Now what are the treatment options? So we are having plenty of treatment options are there. So breathing techniques are there. We call it huffing and coughing. The patient has to take the breath, breathe in, breathe out, breathe in, breathe out, and the cough is there. Autogenic drainage is there. Mechanical devices are there which I will show you. Now in pharmacological things, we are having the hypertonic saline as an expectorant, mucoregulator, mucokinetic, and mucolytics we are having. So autogenic drainage is nothing but it is with the help of breathing technique that uses controlled breathing. So huff and cough technique we call it as, and minimal coughing to clear the secretion. Sometimes we ask for this postural drainage. So with the help of postural drainage also, this secretion is cleared out because the whole protective mechanism or whole parenchyma is fired out or destroyed. So it is normal, it is not normal, so the patient is not able to expectorate the sputum normally. So what are the things, what are the machines are available, a cappella and other devices are there. If you talk about these devices. Then chest physiotherapy and postural drainage, so we have to clap the chest wall of the patient from the backside. This clapping and chest percussion will help out, and that will remove the sputum or whatever the mucus plugging is there. Now coming about the main content of the slide, this topic, overview about the hypertonic saline. You know that before that I will shortly tell you about what is nebulizer. So it is a nebulizer is a machine which converts liquid medicine into aerosol mist, which is easily inhaled and absorbed. Through this nebulizer device, you can give a larger amount of dosage. So it is a pressurized or compressed air. It is turned into the mist. So invention of nebulizer, in short, the first electrical pressurized nebulizer was invented by the Sales Garrion in 1858. So the beauty of this nebulizer was, so here this was the storage. Like we are having the nebulizer chamber. So drug was stored in this chamber. and it worked on the bicycle pump. So upon pulling the pump, the drug used to come in the pump, and upon putting the pressure, the fumes used to come.
So
this
2
was
minutes
the-
remaining. So 2 minutes remaining.
Oh yes, yes. So I will finish with that. So hypertonic saline is a concentrated. So whatever physiological saline we are using is 0.9%, and this varies from 3% to 7%. Okay. So what is the mechanism of hypertonic saline? It decreases the viscoelasticity of the airway secretion, breaks the ionic bonds, increases the depth of the surface, stimulates the movement of the cilia, and causes sputum induction and cuff, which helps to clear the sputum outside, absorb the water, and these are the things which this hypertonic saline take care. Whatever saline which we are using is 0.9%, that is physiological saline. Hypertonic saline is 3% or 7%, which we are using for induction of the sputum in tuberculosis patient. Whenever the patient is unable to bring out the sputum, we give the nebulization with the 3% saline, and that helps in bringing out the sputum. So there are several studies. In acute bronchiolitis, they use this nebulized hypertonic saline. That has shown, the study has shown that the length of the hospital stay with 3% nebulized saline was lower, shorter duration of respiratory signs and symptoms, clinical severity score was less, adverse events was not there, and nebulized hypertonic saline when used in conjunction with other bronchodilator, so the efficacy was very much better as compared to other. In bronchiectasis also, there happened one study, and the result is significant improvement in the lung function. Need of antibiotic usage was low, adjunct antibiotic, and reduction in the emergency healthcare visit was also low. So this is, I will not go in this. So what is the mechanism? So the mechanism is non-invasive, simple, cost-effective hypertonic saline. It increases the osmolality of the airway, vascular permeability is increased, and it induces the production of the sputum by submucosal gland. So the concentration once again is used for sputum induction is 0.9 to 7%. And duration of the nebulization, as ma'am has already explained, it should be given for 15 to 20 minutes. And ultrasonic nebulizers are must for this hypertonic saline, and pre-treatment with bronchodilator like salbutamol 200 to 400 microgram is recommended.
So 20 minutes over.
Sir. So what are the guidelines in favor? So ERS, CDC, NICE and NSW guidelines, they favor that more effective, this sputum for hypertonic saline is more effective than normal saline for induction of the sputum, and the CDC also is in favor of this hypertonic saline. So the last slide is, it is safe when tolerated nebulized hypertonic saline in patients of all which we have discussed. Caution is necessary in patients of congestive heart failure or renal failure, should not be administered immediately after other inhaled medicine, and there is no significant adverse effects have been reported, and there is a chance of rare case of bronchospasm with this hypertonic saline. With this, I end this talk, and I am very much thankful to again Dr. Kutte sir and the whole team, organizing team of this Mastacon 2022 and the respected delegates. Thank you all for your patience.
I will request Dr. Rajat and Dr. Aishwarya to felicitate Dr. Sahir sir. Thank you so much.
Thank you very much for giving this moment. So our today's topic is strategic approach to the patient of inflammatory arthritis. And as we all know, I am Dr. Gopal, working as a rheumatologist and diabetologist at Nucleus Hospital Research Center. Our hospital have received recently the Best Diabetic and Rheumatology Center from the auspicious award from the auspicious hands of Governor and the Honorable Health Minister as well. So with regards to the topic of strategic approach to the inflammatory polyarthritis, as we all quite aware that the inflammatory arthritis is basically an autoimmune condition, and most of these autoimmune conditions are perhaps more common in female rather than a male, and that too in a very productive age group, that is from 20s to 50s. The happening the disease into this particular age group leads to the excess social, economical and financial burden on the patient. And if they are not diagnosed at a proper period of time, can lead to the devastating joint damages, and patient has to suffer a lot in their lifetime. So approach is very important. So if you look upon this diagram, the onset of the disease, and if after the 10 years of onset of a disease, 60% of the people with inadequately treated rheumatoid arthritis are unable to work for the 10 years after the onset. So had they not been properly diagnosed and treated at the onset itself, after 10 years, 60% of patients will land up into the multiple complications. The joint erosions eventually develops at the age of, from the onset of the disease up to the age of 2 years. So we do have a window of opportunity to treat exactly in between the first and the second years of onset of a disease, because after the 2 years, if the joint damages have already been happening, we are not able to correct those deformities. So 40 out of 1 lakh patients are diagnosed with an inflammatory arthritis each year. RA increases the risk of the infection, heart attack and stroke. It's not only about the arthritis only, but they do have extra articular features as well. People with rheumatoid arthritis are 2 times likely to suffer from a depression, and rheumatoid arthritis is expensive with regards to the medical cost and the productivity cost as well. So RA is having a heavy burden on society in terms of disability, health and economic constraint. So whenever we are diagnosing a patient, we need to have 3 things in our mind. Trying to treat, because if you lost the window of opportunity of treating these patients in an early period of time, the patient may develop the joint damages. Treat to target, which prevents the morbidity and the mortality, and the targeted therapy. The targeted therapy in terms of conventional synthetic demands, biological demands, and of course there are targeted synthetic demands as well. So these are the newer drugs. And if you are using these newer drugs at a proper period of time, they accelerate the remission and of course improve the quality of life of the patient. So whenever we do have a patient, the basic principle is to know what exactly the problem is. So the first is whether the condition is acute or chronic, because the only chronic condition can lead to the joint inflammation, swollen joints, and of course the joint damages. So the second is whether it is a monoarticular, oligoarticular or polyarticular, which joints are involved, whether the smaller joints or larger joints, what is the pattern of the involvement, whether it is the axial involvement or whether it is the peripheral involvement, is it symmetrical or asymmetrical, is it basically an articular or non-articular problem, are there any features of the joint inflammation, and are there any extra articular features. So if you address all those issues, you might be 100% in a position to diagnose any condition of an inflammatory arthritis. So how do we diagnose whether it is articular or non-articular? As we call it quite aware, articular is basically from a joint capsule, periosteum, ligament, subchondral bone and the synovium. While the non-articular is fascia, muscle, tendon, nerve or like skin. The pain is along the joint and the articular, while it may not be with the non-articular pattern. Articular disorder may be characterized by the deep and the diffuse pain, while it may not be the condition of the non-articular. The most important range of movement, because the limited range of movement on both active and the passive movement does happen with the articular, while it is only with the active in case of a non-articular. So inflammatory and non-inflammatory. So we do ask only 3 questions of the patient, whether there is a stiffness, swollen joint or a painful joint. If all of these are positive, that does mean the patient is suffering from an inflammatory arthritis. You may get a stiffness in the non-inflammatory condition as well, but the stiffness will last for less than 30 minutes, while the stiffness in the inflammatory arthritis usually lasts for more than an hour. Fatigability, especially we might have seen a lot of young female patients who that suffer from a lot of fatigability, and fatigability because of a release of acute inflammatory markers does present with a lot of inflammatory condition, connective tissue disorders and vasculitis as well. So fatigability is also one of the major complaints. A temporal pattern of the arthritis is very important in the sense whether the disease has been occurring within hours, whether it is an abrupt onset, because within hours if the disease is happening, it could be infection, traumatic, or it could be a crystallopathy. While if it is an insidious onset, chronic duration, then we do have all the inflammatory conditions or an osteoarthritis as well. So the history is very important. A distinctive types of the musculoskeletal system involvement, like a spondyloarthropathy, they are a chronic, asymmetrical, axial kind of a pain. While the other inflammatory arthritis like rheumatoid, they are a chronic, symmetrical, inflammatory, upper limb more than lower limb. While the spondyloarthropathy, they are asymmetrical, backache might be the initial symptoms. They do have HLA-B27 positivity, enthesitis. So extra-articular features are quite common with the spondyloarthropathy rather than a inflammatory arthritis. So these are the frequently encountered pattern of a polyarthritis. So if you look, historically, if you check all of these joints in a proper way, 100% at the end of 5 minutes you might be in a position to diagnose which kind of arthritis we are dealing with. So RA pattern, it is basically a chronic, symmetrical, inflammatory, peripheral, upper limbs more than lower limbs, small joints more than large joints. So if you are getting this kind of history, this is a rheumatoid arthritis. While a psoriatic arthritis, they are asymmetrical, package is the main symptoms. They do involve DIP, which is not the case with the rheumatoid arthritis, and they usually have an axial kind of involvement rather than a peripheral kind of involvement. Axial kind of involvement pertinent to the SI joints only. So the reactive arthritis, the same again, asymmetrical oligoarticular arthritis, while rheumatoid is the symmetrical polyarticular arthritis. Spondyloarthropathy, they are basically axial arthropathy, while inflammatory arthritis, they are basically peripheral arthritis. So SI joint involvement, large joint, lower limb, and they do have a lot of eye, skin and the bowel symptoms to start with. Axial spondyloarthropathy, they do involve axial skeleton, sacroiliitis, and they are oligoarthritis by their nature. Osteoarthritis pattern, they could be symmetrical or asymmetrical, but the most important thing is they don't have joint stiffness lasting for more than an hour. The age is not impertinent to the inflammatory arthritis. They do involve a larger joint, and all joints, probably the weight-bearing joints are involved. So whether the condition is articular, non-articular, whether it is inflammatory, non-inflammatory, whether what is the duration basically, acute, subacute or chronic, whether it is a polyarticular, oligoarticular or monoarticular, and was it a symmetrical or asymmetrical? If you ask all those questions, definitely we will be able to diagnose any disease historically. So after historically, we need to examine really the patient is suffering from inflammatory arthritis condition or not. So squeeze test. So swelling, synovitis. Swelling is a joint inflammation, and the swelling does present if there is a severe pain and stiffness. It is suggestive of synovitis. So for synovitis, you may have stenosynovitis and a plain synovitis. The squeeze test is helpful to know whether the patient is suffering from a synovitis or not. So historically and clinically, you come to a conclusion that the patient is having certain sort of an inflammatory condition. It is a time to investigate the patient, and the investigation in the rheumatology are pertinent to ESR, CRP, ANA, ENA, RNP, SMAIL, cardiolipin, PNK, CNK, complement, histone. We will not go into the details. The important thing what we need to know, when the ANA should be ordered, how to interpret ANA, because ANA is the most commonly misinterpreted investigations by most of the physicians. Moment ANA is positive, that does not mean that it will definitely correlate to the disease, and the pattern of ANA, titer of ANA, intensity of the anti-nuclear antibodies are also very important to document. So what does basically ANA is? As the name suggests, it is an anti-nuclear antibody. So our body is made up of a lot of cells. The cells have two components. One is a nucleus component and another is a cytoplasmic component. So these antibodies are targeted against the proteins in the nucleus. So what are the proteins which are present in the nucleus? It could be double-stranded DNA, ribonuclear protein, RNA, histones, centromeres. So there are a variety of antigens which are present as the proteins into the cell nucleus. So if these antibodies are basically targeted over those antigens, so these are anti-nuclear antibodies. Similarly, the antigens are also present in the cytoplasm. They are called as anti-cytoplasmic antibodies. So ANA are antibodies which are directed against the certain components of the nucleus. It could be DNA, RNA, histone and centromere. The three most important things whenever we are dealing with the patient, whenever we are reading the patients of anti-nuclear antibody testing, titer, what is the titer of that ANA, what is the intensity and what is the pattern. Because if you know all of these three, you will be confident to conclude, you will be in a position to conclude what exactly the patient is suffering from. So the important thing is positive ANA does not mean that the patient is suffering from the disease itself, especially in the low titers. ANA does not relate with the disease activity at all. it should be used to diagnose the patient along with the relevant clinical and historical examinations. Consider doing ANA only in those patients in whom we are strongly suspecting that the ANA could be positive. It's not that the every inflammatory condition you are asking the patient to go for ANA. And the ANA interpretation, especially in the patient of juvenile idiopathic arthritis, is helpful to assess the risk of the uveitis. The another test is anti-neutrophilic cytoplasmic antibodies. We will not go into the details. It is basically present whenever suspecting a vasculitis, unexplained arthritis, rheumatoid factor. It is uncommon in children, should not be used as a screening test for the rheumatic disease in the children. Only indication is for a polyarticular GI if you are dealing with a patient of an pediatric age group. In an adult age group, low titers are commonly seen in the healthy children as well, so less than 5% or 5 to 10% of the patient may have RA positivity, and RA positivity does not mean that the patient is suffering from an rheumatoid arthritis. It does happen with the infection like viral infection, certain sort of bacterial endocarditis as well, malignancy, and it may have a present in the SLE patients as well. So high titers are usually seen in the JIA and predictive of neurogen arthritis. HLP27, it is one of the histocompatibility gene which is important in the transplantation. HLP27 in the rheumatological aspect or rheumatological perspective is present basically in the patient of spondyle arthropathy. The spondyle arthropathy you may have AS, IBD, psoriatic arthritis, reactive arthritis, and less than 20% of the patient with the HLP positive, which are HLP27 negative, also can develop the AS. So it is not per se that the HLP27 is a prerequisite for diagnosing the ankylosing spondylitis. Of course, the clinical examination is very important along with the symptomatology of the patients. The complements are usually helpful to document whether the disease is active or not. We will not go into the details. Then a patient of monoarthritis does suffering from having all the historical and clinical clues that the patient is having an inflammatory arthritis condition, and we are in a dilemma whether it is a inflammatory or non-inflammatory. Then the synovial fluid analysis can also be useful. The synovial fluid analysis, the normal white blood cells are 0 to 200. In the non-inflammatory condition, it could be less than 2000, and in the inflammatory condition, it could be 2000 to 50,000. And to diagnose the patient as septic arthritis, the WBC count in that particular synovial fluid examination should be more than 50,000, and out of which more than 90% should be a neutrophil. Another synovial fluid examination is helpful in diagnosing whether the patient is having crystallopathy or not.
Sir, 2 minutes remaining.
So imaging, we do have a lot of investigations to image. This is more important whenever you are having a patient who are suspecting inflammatory arthritis. You just count all those parameters and try to engulf those count into these RA classification. If it is more than 6, then it is definitely RA. In treatment perspective, if the patient is DMARD name, the disease activity is very low, you can start DMARDs straight away. If the disease activity is very high, you can start at 2 DMARDs. After the combined effect of DMARDs, you assess the patient's clinical judgment. If the clinically the patient is not getting better, then you can add on the more amount of DMARDs, or you can add the biological therapy as well. So when we use steroids, interstitial lung disease, vasculitis, and the eye complication, so these are the drugs which are present with us. The first is conventional synthetic DMARDs, methotrexate, cyclophosphamide, sulfasalazine, leflunomide. Biological DMARDs like anti-TNF, anti-IL-6, anti-B-cell, and so on. And the targeted synthetic DMARDs like tofa or baricitinib. So these are the DMARDs. So categorization of the patient, we do categorize the patient in the disease activity and the poor prognostic factors. The disease activity measured in terms of a DAS index or a clinical DAS severity index. Low is less than 2.5, moderate 2.5 to 5.1, and the more than 5.1 is the severe. So the drugs which are allowed during pregnancy, corticosteroids, hydroxychloroquine, azathioprine, tacrolimus, cyclosporine, and sulfasalazine can be used. And the drugs which needs to be avoided is rituximab, mycophenolate, cyclophosphamide, cholinesterase, and leflunomide. How do we preserve the fertility in terms when you are using a patient of cyclophosphamide? You can use a GnRH agonist. What is the treat to target? The treat to target is at the end of the treatment, the patient should not have any swollen joint, tender or painful joint. Patient's average pain score should be at least 1 to 2 out of 10. A patient with pain swollen joints may feel better with the 5 swollen joints, but escalate till the target is achieved. And the treat to target these results into no less deformities, better quality of life, lesser pain, lesser fatigue, and less cardiovascular disease. So if you're targeting the patient at a proper period of time, we may have an opportunity of window to have a less erosions, because this is a natural course of it. This is the first one. And if I'm not able to target the disease at a proper period of time, the patient should have a lot of erosions, and the ideal course should be at the end of a disease, at the end of a treatment, the patient should not have any pain, stiffness, or swollen joint. So this is how we calculate the DAS severity index, and these are the simplified versions of that. Thank you very much.
Thank you so much, sir. Now I request Pranali ma'am to please felicitate him. The speakers on behalf of the organizing committee.